Much, and apologies everyone for the slight delay. Welcome to this hybrid meeting of the IGB, particularly in light of recent weather. I would remind all attendees that this meeting is being recorded and hopefully webcast live YouTube channel. I've agreed the attendance of some members, perhaps more than usual. I'd remind all remote attendees to mute their microphones when not speaking. Thank you very much. And before we start the agenda proper, I really want to speak on behalf of the IGB. I'm sure you'll agree that we extend our heartfelt sorrow to the people of Brechin, Monteith and the surrounding area around about Brechin for the deluge they've experienced over the weekend. And a huge thanks to staff who yet again have gone way above and beyond the call of duty in making sure that we look after the people who depend on our support, and they have done it with scant regard to their own needs, that people have been looked after. This is going to be a really long haul, and I mean, we have obviously had a commitment from the Scottish Government that they're in it for the long haul too. So I really just want us to look out for each other, because resilience will be struggling. People will be finding it hard to keep going with this level of demand, and I really hope that they look out for each other too. I really would encourage all of us in this room, for each other around the table, and for our colleagues who aren't in the room today. We really do value everything you do, and hugely grateful, and just thank you so much on behalf of everyone. We will be with you every step of the way. Thanks. And if we could move to apologies, please.
Yes, Chair, there's apologies from Tracy Bowman and Hayley Mearns, and Donald McPherson is the proxy member for Tracy Bowman, and he's joined remotely. Councillor Speed, Dr Emma Fletcher, Catherine Lindsay, David Coulson and Barbara Tucker have all joined the meeting remotely.
Thank you very much, and welcome, Donald. Good to see you. So can I move to item 2, please? Any declarations of interest or state day? Not seeing any hands up. Okie dokie, thank you very much. So item 3, which is the minutes of the last meeting. If we take the minutes first, if you don't mind, that's page 5 of your pack. Any queries or corrections relating to the minutes? Not seeing any hands up. Can we then an accurate reflection of the meeting? Everyone happy? I'm seeing nods. That's great. Thank you very much. Okay, if we can go then to the action log on page 13, and if Gail's going to pick that up to start with. Thanks.
Yeah. That one, yes, thank you. This is actually a positive, like you're looking at a number of reds. Can I start with item 5 on page 14 of your pack, and the Tayside Primary Care Strategy? You'll see in the note that this was due in August, and we agreed to bring a progress update in October, and I'm pleased to say that that is on the agenda for today. The next red we've got still on page 14 is item 15, and again that was the alcohol and drugs part 8, and that as well is on the agenda today in item 12. Prescribing management, which is partly on 14 and page 15 as well, and again that update is due for December. We move down page 15, and item 4, adults with incapacity. As we've said previously, all outstanding actions remain on target, and that update will be brought forward again in December as planned. And item 8, the Angus IGB Strategic Financial Plan. Again, as noted previously, that update has been included in your pack today, as noted on item 14. Thank you, Chair.
Thank you very much. Any questions from anyone on the action log? Yes.
Thank you. Sorry. Can I ask for clarification on the first item in the action log, the daycare report? The text refers to the further report, which was agreed at the last meeting, but refers to including risk appetite, which I do understand, and clinical impact, which I have trouble understanding what the nature of that is with regard to daycare. There was no reference to clinical issues in the discussion, nor in the minute, and I would struggle to recognise that, and I think I would be more comfortable with something that reflected the nature of what we're looking at.
Thank you, David. We'll get that picked up. Yeah.
Thank you, Mr Mackenzie, for your question. I think we need to also clarify what clinical input is, because John and I are also querying that, because this is a sort of social services service, the daycare discussion about the impact on other parts of the system, with the daycare. So I think maybe that. So thank you for highlighting, and we'll get that amended. Thank you.
Thank you, Eunice. Yeah, you happy with that, David? Yeah. Lovely. Thank you very much. Any more questions on screen or around the room? No. Okay. In that case, we can move on from the next agenda item, which is the Chair's Assurance Report from the Audit Committee. And I just ask the Chair, Andrew Jack, to do a brief introduction. Thanks.
Yeah, thank you, Chair. This is the second of this type of report that we've produced, and we've settled on a kind of standard format, which we hope will be easy for the IJB members to read and digest. The kind of nature of the reports reflect the audit work in general, which is kind of steady and incremental. So hopefully there's not too many surprises come out of these reports. Attached as an appendix is the actual full minutes of the August meeting that we had. We didn't have a meeting today, but we had our annual development session, which was very, very useful. And next time we'll report will be at the December meeting. But that'll probably be the April meeting for the December audit committee. So if anybody has any questions on the summary or the substantive attachment itself, then either I or Sandy would be happy to answer them. Thank you, Chair.
Thank you very much. It's incredibly useful, so I do appreciate the work that's gone into them. Anyone have any questions on this item? Are we happy to note that? That's all we're being asked to do. Okay, thanks, lovely. Thank you very much. And then it will be item 3D, which is the Planning Group Chair's Assurance Report. I'm hoping you'll all have read that. I certainly found it useful. I feel much more connected to the SPG by seeing these notes. I find it hugely useful. So thank you, Chair, for providing those. And it would be Jill Galloway that takes any of them. No, everyone happy to accept that. Thank you, very informative. And if we move on, and just as we're moving on to the next item, I found the development session that we had with the IGB and the SPG members incredibly useful. I know some members have already fed that back into other fora around the importance of prevention, early intervention agenda. That's one that we've been talking about a lot, and it's been great to see a lot of those projects. So a very event, and hopefully an ongoing opportunity. Thank you. So if we move on to item 4 now, that's the finance report on page 33 of your pack. and I'm sure Sandy will want to come in and introduce that. Thank you.
Yeah, thanks, Chair. I'm just going to highlight a few points and then happy to take any questions. I'll do that just as we go through the paper. Section 2 in the background, we highlight the forecast position for the IGB. We are still expecting or forecasting an underspend at the moment in this financial year for the IGB. A number of risks, I'll cover a couple of those in a second. And the reasons for the forecast underspend are set out in section 4 of the report. Of the points I'd like to highlight, the first one is in section 3.4, which is about prescribing. And this is an area of risk for us. Is issues associated with the timeliness or the timing of us receiving information about prescribing costs. We normally have a 2-month delay in terms of receiving prescribing information. We've all said that many times. But due to issues that we're currently experiencing a 4 to 5 month delay in receiving information about prescribing costs. It's a budget of over £20 million. There's an element of volatility and uncertainty in there through volumes and pricing. So there's a big risk in terms of our ability to estimate the costs that have been incurred over the last few months. So I think we all need to keep that in mind, and as that risk hopefully resolves itself, we'll gradually update the committee. Moving further on, section 3.6 of the report, inpatient mental health services. Again, just highlight another kind of unresolved issue, a bleak risk here. We do still have ongoing conversations with NHS Tayside and other IJBs regarding how the overspends that are likely within will be partly resolved, but also funded in this for ongoing. I'd also like to highlight section 3.7. That's large hospital services, often referred to as large hospital set aside. We have included some activity information, possibly for the first time, and if not for the first time in a long time. We're gradually with the development of generally performance information and linking up performance information and financial information. And I think I hope and you should expect that section will develop in this report. And it's just highlighting how the Angus population's use of occupied bed days captured by this definition of hospital use has changed since pre-COVID. The levels are still lower than when the IGB came into being in 2016. The next area I'd like to highlight is in section 310, page 38. There's a table there showing where we are with financial planning interventions and things that we're hoping will help us square away the strategic financial plan over 3 years. You can see there's some progress, but not the kind of level of progress that we would hope. And the update captured in that section of the report ties in with one of the action points that we saw earlier on the agenda. The next point I'd like to highlight is in section 5.3. It's under the heading of reporting. We had done a kind of an informal survey of board members to make sure that they were responsible with the content of finance reports. And the general consensus of the feedback we got was yes, they are okay, and the content is okay. We'll continue to modernise and iteratively improve that. The things that are emerging in the IGB, always trying to make sure these reports don't get too long, and sometimes they do get a wee bit long, because I think this is 14 pages, but we'll keep that in mind for everybody. And Chair, the last point I want to mention is in Appendix 3, page 44. This is about reserves, and this ties in with one of the recommendations in the report, and there's a section towards the end of page 44 at the bottom of Appendix 3, where we're noting that we do have some reserves that aren't utilized within our plans. They are partly reserves that are built up at previous year ends. And as we have done in previous years, we're suggesting that we do try and mobilise those to partly meet the IGB's, support the delivery of the IGB's strategic commissioning plan, but also to acknowledge that the environment we are operating is one that does involve other partners. So there is a suggestion in here that ties in with the recommendation on the front page about seeking to develop and progress proposals to deploy these reserves, bearing in mind they are one-off funding. I say it's a similar kind of angle to how we've addressed issues such as this in the past. And Chair, I'll stop there, but
Thank you very much, Sandy, and I appreciate the movement on the large hospital set-aside issue. That's great. Does anyone have any questions? Yes, first up is Chris Boyle from staff side, and then...
Thanks for the report, Sandy. It's just for confirmation, section 3.8, page 36. I'm assuming, I assume the board will assume that you're referring to the enablement and response team rather than the emergency response team that you refer to at the bottom of page 36.
Yes, Chris, that is absolutely correct. I'm not quite sure how that has crept in there, but that should be the enablement response team. And sorry, I should have corrected that already. Thank you.
Thank you, Hawkeye. That was well spotted. Excellent. Councillor Speed.
Do you know what? I must have Hawkeyes too, because that was actually what I was going to come with. But just I wanted to ask actually a little bit more on that, and just if there could be a bit more of an explanation in terms of it says that this would be a short-term plan, that team would be able to recruit just until, I think, was it March next year. Just if we could get a bit more information on that, and just what will then happen, how just for a short term, I guess, is my question, and what will be done after that then with, you know, those staff, what will happen with their employment?
Thank you.
Yeah, thanks, Chair. I'll come in initially, and you might, or John might want to pick something up on that as well. This is a short-term arrangement at the moment. It's been in place for this financial year. It was also in place in the last financial year. And it was a response to staffing issues that we've documented, the unmet need issue that we've documented in terms of the provision of care at home. Although we said short term, we're not doing this on a month-to-month basis. We've tried to give the people involved as much notice as we can and as much kind of certainty as we can about the arrangements. And that's why we've got them in place currently through to March 2024. It's probably reasonable to say that not all our issues regarding unmet need have been fully resolved yet, and we might have to revisit this issue as we approach the end of the financial year and looking forward. I think most of the staff, again, John will come in a second, or maybe Eunice will come in a second. Most of the staff, I don't think we've engaged additional staff. It's staff who've been working additional hours. So there's a slight kind of bit of detail in there in terms of the employment status. But this is something we'll definitely keep under review. And this is just a temporary position in terms of our response to the unmet need in this year. But I will let one of the heads of service.
Thanks, Sandy. Yeah, you've really said what I was going to say. Councillor Speed, the staff, there's no additional new staff that have been taken on as staff who we already have. They have had additional hours added to their contracts to enable them to undertake the work. And as Sandy says, it's to meet that level of unmet need at this point in time, and will be reviewed in due course as we go forward. Thank you.
Thank you, John and Sandy.
Yeah.
Do you want to, are you coming back in?
Thanks, Chair. Yeah, if I may. So just for clarity, is this almost like there's been a kind of a revision of what was originally the Help to Live at Home team?
Not specifically, and not on a strategic basis, Councillor Speed. This has been an operational response to our issues regarding, and we were looking at areas where we would be able to try and help manage some of the unmet need issues. And one of the areas where we felt we would have the scope to do that was through the enablement response team, which is not the same as our core. That team doesn't have the same kind of objectives or targets or responsibilities as our core care at home teams. So we were using the staffing resource that we kind of manage directly to help us manage the operational issues associated with unmet need. I think, though, this issue about unmet need, of course, I mentioned a second ago, it hasn't gone away, and it hasn't. And it's something that we're continually reviewing to see what are the long-term solutions. And I think that's probably, and without kind of prejudging what your concern is, we are absolutely looking at how we resolve the issue about the long-term issue regarding resolving the unmet need issues. We haven't reached, I don't think, a definitive position about that, but there'll be a number of things under consideration.
Mm-hmm. Yeah, I think what I was seeking clarity on was, sorry, there's really bad echo. What I was seeking clarity on was, are the staff within that team, I guess, carrying out duties that the kind of old in-house council helped live at home team carried out?
Thanks. I'm going to bring John in there.
Yes, Councillor Speed. No, the staff are undertaking duties commensurate to what their role is as ERT employees. It's really just to meet that additional amount of work that is required at this point in time.
Okay, thank
you.
Thank you. Peter, and then Chris. Okay, Chris.
Yeah, thanks for that, Peter. Yeah, I was just noting, John, what you said about that this isn't Sandy, a new resource. This is existing members of staff taking on additional hours. That is very short term. You've got people who may be on 24-hour contracts, be extended to 30, those on 30 and upwards. Very short term fix. Some people may not want those arrangements permanently, for sure. And there's only a limited and finite amount of hours that you can actually add on somebody's contract before you actually end up sort of kind of get close to working time regulations, for example, or working hours regulations. So it's in terms of to flag that up as a concern that we can't keep overworking, or the perception of overworking existing members of staff, because we end up with burnout, we end up with staff being off unwell, with health related issues, stress. Very short term fix, and we'd obviously be keen on behalf of the staff involved in these services that, you know, there are medium and long term plans, proposals, innovations in place, that we're not relying on a shrinking workforce to deliver even more all the time in order to meet that unmet demand. And I think, you know, as far as our staff's welfare is concerned, it's a really important point for us.
Thanks, Chris. And we do obviously have the workforce plan on the agenda today as well. Does anyone want to come in on that specifically? Okay.
Thank you, Chair. Yeah, thank you for the question. I think it's a fair point. The well-being of our staff is always at the forefront of our going forward. So I think, firstly, just to give assurance that all members of staff within ERT receive regular supervision and support and training aligned with the also worth noting that many of these staff are part-time contracts as well. So they have agreed on a voluntary basis to undertake these additional hours as required. We do know that that is something that can't continue forever and a day. There's also a service review being undertaken at this point in time too, which is taking into account the needs within the community, needs that often ERT and our commissioned services for care at home have to respond to. So that will very much be contained within the overall service review as well. So a number of actions going on that are keeping us abreast of the situation and looking to make sure that there's more robust plans in the future for this.
Thank you very much. Peter.
Thank you, Chair. Thank you, Sandy. Another really detailed report, and I do take great assurance that our finances are in very good hands. But the report obviously mentions quite a number of risks and uncertainties ahead. Based on that, how confident are you in these projections? I'm referring to the recommendations. So with accepting the overall projected financial position, you know, how confident are we in the accuracy of these projections, considering these risks and uncertainties that we face? And I suppose because we're also asked to scrutinise and note the issues, large hospitals set aside, I note the limited progress on this still. Could you just, or your colleagues, provide a little bit more context on the impact that this is having on the IJB, on their ability to direct resources and the progress being made in this area anytime soon? Thanks.
Right. Thanks, Peter. I'll deal with the first question, and I might bring Jill in a bit on the second question. So in terms of how confident we are about these, I shouldn't say this in a public meeting, but you know, probably not as confident as one would like to be. And I think that's, I mean, we've spoken about this actually at the Audit Committee development session today. We were talking about horizon scanning of risks. And, you know, we talked about the environment we're operating in, which is probably one of more uncertainty than probably most of us have experienced in our working lives. And therefore, you know, linked to that, probably more risk than we've seen. There are things in here that have been documented for quite some time and haven't gone away. And there are new things kind of coming in all the time. So I couldn't be sure this is how this is going to pan out. I think what I would probably say in it, maybe a few years ago, I might have expected individual service projections to move a bit up and a wee bit down as we went through the year. But there are some bigger things in here. There are some things that are unresolved. For example, the arrangements regarding mental health services. There are things where the data hasn't flowed through to us. Good example is the prescribing stuff, where we've got millions of pounds without clear data coming through. So there are regular risks, but there are also some big things that could move our numbers either way. So to some extent, we're just given our best estimate of things right now, but I couldn't guarantee it's how it will pan out. And there's a recommendation here about how we would potentially look at some reserves. And I think any discussion or any development of ideas around that, if the board agree to that today, will have to be done in that context of, we know there's still a lot of uncertainty to unfold in the next 5.5 or 6 months. So yeah, quite a lot of risk there. In terms of the large hospital set aside, we are doing, I suppose, a couple of things there. We developed some ideas on a working kind of in principle basis with NHS Tayside. That was more about the financial arrangements and how that would flow through. And I think we're still in discussion with NHS Tayside. It's more about hopefully crossing T's and dotting I's about that. That itself, those are linked to having a good understanding, a regular understanding about the activity levels, which is why we start to build them in here. And that in itself ties back to improved reporting of performance generally throughout the IGB. This, though, I don't think is necessarily inhibiting the development of a closer and better working relationship with NHS Tayside regarding this type of activity. And having set you up, Jill, I'll pass you on, because Jill is more kind of closely sighted on some of the detail.
Thanks, Andy, and thank you, Peter. I think and some of the work that we are undertaking around large hospital set aside is to really understand in admissions. What we aren't sure about at the moment is how much of that is still a kind of lingering impact of COVID, particularly around people who are waiting on planned elective procedures, and is that having an impact on potentially unscheduled admissions to hospital. So whilst our levels are higher than what they were pre-acknowledging that they're still lower than what they were in 2015 and 16, we really need to understand, and there is work ongoing to understand why people are being admitted. How else can we support those individuals in a more proactive way? So bringing in some of that proactive and preventative approach to that. If they are waiting for surgery, how can we support that prehabilitation with them so that actually when they do go in for surgery, their post-surgical rehabilitation is less, because we've done a lot of work from a preventative perspective. I think it also reflects the general increase in demand and activity, which I don't think there's any service an increase in demand and complexity. So I think it's multifactorial in terms of the reasons, and we're just really trying to get underneath some of that data to understand if we can indeed understand the absolute reasons why. Alison might want to come in because the waiting lists are a big challenge for us.
Please do, Alison. Thanks.
Thank you, Chair, and thank you, Jill. So, as Jill says, there's a number of areas where we can look at what is causing the increase in admissions. We have worked through the Performance Steering Group doing an audit, and that is bringing people together from secondary care, primary care, nursing background, AHP, to actually look at our admissions and readmissions and see what it is that is behind these admissions and whether there's any quality improvement work that we can take. So very keen throughout the finance report that this is changes that are being made are around financial sustainability, but taking a quality improvement approach and not about cutting services, intelligence, and take the time to get that data. So I mentioned that audit. The other thing that I would reference is the links between unscheduled care work and the Planned Care Board. I'm fortunate to co-chair with Chris Schofield from Secondary Care the integrated work stream of the Planned Care Board for NHS Tayside, and we are looking at long-term conditions, referral guidance for GPs and other and diagnostics, trying to look at how we can work better to improve people's health, not just about preventing ill health, but managing long-term conditions. And through all of this work, we're hoping to identify priorities within planned care to look at proactively to prevent the unscheduled admissions and how we can link things up. So really taking a strategic approach to that. Thank you.
Okay, and Gail wants to come. Thanks, Alison.
Yeah, Peter, in answer to your question, some of it is guesswork, as Jill was alluding to. Back to the 2015, 2016, 2017, we were on a really good trajectory for avoiding admissions where possible. The work that Sally Wilson and her colleagues are doing around prevention and proactive care is going to be crucial to this. Fundamentally, when you're looking at budgets and you're looking at costs, data is what's important here. So we need to get better at collecting that data, appreciating that that is being refined at the moment, but I think we do need to get sleeker. And I know Brian Reynolds and the team are working on that, but that's going to be where the answers are.
Thank you. And Gail also pointed out to me we typo under 3.7, just the line above the table. There is ongoing refinement of this data, not date, which is why Gail came in on that. So thank you. Any more questions? Peter Drury and then Councillor Meehan.
Thank you, Chair. And thank you, Sandy, for another very succinct report. Although a projected underspend, quite a large one, feels good, it isn't really, and we shouldn't get too comfortable because of the level of staff vacancies, which is, as we see elsewhere in the agenda, very worryingly high. Is that one of the biggest adverse variances or overspends is on 2C practices. Is this a sign of the times, and is it only going to get worse?
If you can put your mic off, please. Thanks. Thank you, Sandy.
Thanks, Chair. Thanks. Yeah, firstly, I agree with your point about underspends not being a good thing. I mean, we're not presenting them as a good thing. We're trying to present the facts of the matter. To some extent, they do sometimes help offset overspends that we have. And you're right to say, use the example of 2C practice. There are also issues regarding our prescribing budgets this year, which are significantly overspending, which they weren't in previous years. I think in terms of 2C practices, there's two angles to that. I think generally we feel we know that a 2C practice, which is one that's managed and staffed within the health service, will cost more than one run on a standard general practice contract, which is through an independent contractor basis. So there will be a premium cost associated with that kind of delivery model. So that, to some extent, in terms of once we have a 2C practice, is potentially not we'll be able to avoid. But in terms of is it a sign of the times, the other angle on that is how likely are we to see us have to rely on 2C practices more in the future? Is that likelihood going to increase of that reliance? It's often been covered under things like our issues regarding sustainability and the sustainability of general practice, which we've seen come through this forum before. And at the moment, we've obviously gone through a period where there has been some instabilities in primary care, largely the result of workforce issues. So there is a kind of almost an inherent cost of having to use the 2C model, and the risk, therefore, is how the risk, our exposure, is really linked to the ability for us to continue to sustain local practices running the existing kind of preferred model of general practice. I don't know if people like Alison or Jill would like to come in and comment or about where we are with sustainability work in primary care.
Alison's going to take you up on that. Thank you.
Thank you, Sandy. I'm well aware of the challenges around 2C practices, and for me it's around how do we ensure quality care and equitable access to high quality care across the region and don't have the variation in access to general practice. I know that there's national work around access and general practice coming out that will be helpful. It's mentioned in the bottom of page 35 around overspend, particularly around the challenges in Brechin, and that position is improving, but I would suggest that we do need to keep the focus on quality, retaining our workforce, because the financial cost of not doing that can result in far greater expense. So for me, it's how does the primary care strategy that we are developing ensure access to high quality general practice and recognise the codependency and impact across the system, because we have seen possibly in Brecon the costs of not investing in the 2C model. And there's a lot of advantages to 2C models in terms of their ability to have a workforce that's linked with the health and social care to support the wider community here. So there are pros and cons, and I would really be very keen to highlight the good work that's going on in our 2C practices in Angus and the high quality care that is being delivered. Thank you.
Thank you. I've taken. If I go to Andrew Thompson there.
Excuse me. Thank you, Chair, and thanks, Alison. I agree entirely with you. I think the quality of care being delivered in our 2C practices is sort of second to none and on a par with anywhere else within general practice, and that's down to the dedication of those who are working within general practice and support they're getting. I think the key thing into this is a sign of our times, and actually preventing the sort of future impact on finance is actually our work on sustainability of general practices. So actually it's the work to avoid general practices reaching the stage that they have to move towards 2C. So actually if we focus our priority on on work on sustainability of the practices that remain the independent contractor practices, then that will hopefully minimise the risk to finance going forward. I think one of the sentences that captures it, and again you picked up on it, about the impact on finance versus the impact on care. There's in 3.1, the first paragraph, will have an impact on service delivery. I actually would have put an adjective in there and will have a negative impact on service delivery despite having a positive impact on finance, because that level of understaffing is critical. And I think the only thing, and perhaps this is me being too sensitive, is Sandy, you described general practices who are not 2C as not part of the health service. I would suggest they are part of the health service, they're just not, they're contracted in a different way.
Thank you, Andrew. And moving to George. Sorry, did I jump on one there? Apologies.
Mine is really just for clarification. Recommendation 2 talks about devolved authority to the IGB Chief Officer, etc., in develop and progress proposals. Do these proposals, or would these proposals come back to the board for ratification? The reason I ask is that if we're looking at nearly a 3 million underspend for individuals be deciding on how to spend that money, is that the case? Or does it come back to the board?
So the way I've maybe written it is not perfectly clear, so it's helpful at least to try and clarify that. In terms of including the word progress, I think I was really meaning and would action and push on and action those things, so not necessarily come back for ratification and approval at the IJB board. Of course, that's why it's in here for discussion, and if the board felt that they did want things back, that would be a different kind of angle to what we've suggested here. One of the reasons for putting that down in that way, and accepting it maybe wasn't perfectly clear, is that sometimes these things do need to be moved quite quickly and they're quite dynamic. That's less likely to be the case in this period of the year. But if we haven't resolved things, we would have to move things that are very. And as some people who are in attendance here who dealt with similar issues last year will recognise, when we were getting towards the end of the last financial year, we were having to deal with some issues to do with this type of thing literally every couple of days. So in a way that didn't really lend itself to getting IJB approval of something there and then. Absolutely reporting back to the IJB saying this is what we did, but not kind of getting IJB sign up. So at the moment, the suggestion here was around allowing those things to be developed and progressed and reporting back, which I think it says in the body of the report. If the committee were less minded to do that, we could potentially bring some propositions back at, certainly probably the December meeting. But after that, when we get into February, March, April, it really becomes a bit more time critical, and we'd have to move things a bit a bit quicker, and that's the one where period when it doesn't quite lend itself to a wider approval to meetings. So I would be happy, depending on what the committee to agree, is if there were things that were in development over the next a few weeks, we could try and bring an outline of some ideas back in December, or alternatively stick with the original proposal. But Councillor Meakin, certainly I was envisaging that we would devolve and let progression happen, including kind of taking forward. So hopefully that gives people something to discuss if they wish to discuss that further.
It does tease out the need to make sure that when those decisions have been taken, that an info report comes to IGB so that you can see what has been decided. And I think between the four of us, if this was to be agreed, as happened in the past, then it's not a simple tick box. There is challenge, there is questioning. I think you would agree, Peter. And I think there is an opportunity there to say, no, that needs to go to the IGB. And if you were to agree to this, that's absolutely part of the decision-making process. Just to give anyone any reassurance, it's about not hindering the officer's ability to progress matters that need to be addressed.
Thanks for the explanation, Sandra. Given some money, I think as an individual, personally, I would quite like to see the option of coming back, maybe not at the later stages, but certainly in an earlier stage. It is a fair chunk. And I think it's probably where possible for the board to decide, but I understand exactly what you're saying, that we can't be meeting every week to deal with things. Thank you.
It might also be possible to send out by email an information bulletin, or do it that way.
Yeah, so certainly we can make sure we're keeping people cited. It's really probably helpful to be having this conversation in October and not at a more critical time in March, April, May, when things were always likely to move relatively quickly. So what we can do is during this phase, we can absolutely make sure we're sharing things through the board papers. And I suspect it's probably unlikely we'll make definitive decisions by, say, the December meeting. So we can continue to update the meeting as we go, and then keep this kind of your ability to continue to make decisions in that smaller group more for the period when we're actually acutely going to need it, which is when things are moving at a relatively quick pace. So it's helpful to have that conversation, and absolutely, if we have IJB meetings every day of the year, we'd be involving the IJB, but I think we're probably not going to have more than about half a dozen. So yes, we'll update at the next meeting and try and keep the board as informed as we reasonably can.
Thank you. No, we don't want that every day of the year. Thank you. Councillor Speed.
Yeah, thanks. I was just coming to say that I'm glad that George has picked that up, because I actually read it and kind of just wrongly kind of assumed that it was going to come back to the progress proposals. And I thought that meant then it would come back to us, because as George highlights, that is a fairly, substantial chunk of money that I certainly should be coming back to the board for an update before there's any agreement.
Well, we'll certainly provide an update, I would suggest, in December of any movement on that. Thank you. Any more questions? Before we go to the recommendations, I just have a small question. I'm just wondering potential impact, and it might be too soon to say, of the weekend events on our budgets, and what's in place to flex that out. Please, Sandy. Thanks.
Okay, so I don't think we know exactly what any financial exposure within the partnership, the responsibilities of the partnership. If there were any costs, they would be one-off costs, and we have got a contingency reserve that we would utilise to deal with that, or try and absorb them within our existing budget. So, I think we'll just make an assessment of things, and if there are costs. They'll have been incurred over a limited number of days, many of them, and hopefully we can manage them. What I don't particularly want to do is go into a detailed exercise after the event of trying to cost something up that's happened and had to happen. So we'll try and deal with that on a proportionate basis.
That's great. I think that assurance that our contingencies will be able to flex around that is. So Lois, is your hand up again, or is that an old hand? That's okay. Gail would like to come in. Thanks.
Yeah, just for information for the IGB, a recovery group has been established there. So there may be some costs in relation particular to staffing and things due to some of the issues that are emerging. But both Eunice McLennan and John Cooper will keep you abreast if there are any issues that are emerging.
Okay, thank you. So before we go to the recommendations, I think that second recommendation requires a little bit of additional detail before we ask the IGB to recommend it or to approve it. People happy with an addition around with information reports coming to the board, or with reports coming to the board for either information or a decision? Because that might change. Might be that Tina has a view on that.
Yes, thank you, Chair. I just wonder whether it's really the position now for members to consider recommendation 2 as it is and make a decision on that as to whether or not that's to be moved in its entirety or not.
Okay. So that's the first decision then. Are we able to have recommendations, and particularly number 2, or does that come out? So you're nodding, Peter, but I'm not able to interpret that nod.
I'm happy to approve all 3 recommendations as they stand. Thanks.
Are we happy to approve those? Okay. Councillor Meakin is not happy to approve, and I'm seeing Councillor Speed's hand up there.
Yeah, I'm not happy to approve either.
So we take out recommendation 2, and as it stands, can we reword it? We're happy to reword it along the lines that I suggested already.
Yeah, along the lines that Sandy had said, yeah.
Yes. Happy with that, Sandy?
Yeah, I absolutely acknowledge the comments that Councillor Meakin and Councillor Speed have made. As I said a few minutes ago, I don't think we're in the situation where we have to make decisions right now between, say, now and the next meeting. We are in a period where we're still developing ideas. So I would be quite happy if we wanted to take out the words "and progress" in the sentence, so develop ideas. And at some point, we might come back and change that to develop and action, but we can decide that at a further meeting. So that allows us to crack on and say at some point, and hopefully all the members could see at some point we'd probably need the ability to action as well. Does that feel okay? Okay, so there's another option emerging, and I think we'll go back to Tina for that.
Yes, thank you, Chair, through yourself. It's just whether or not, just based upon what your explanation has been there, Sandy, as to whether or not the recommendation 2 can simply be deferred to the next meeting.
I'd probably rather not defer that. I'd probably rather we had flexibility to start developing ideas, because we obviously have lots of moving parts. And if we put that off too long, we run out of time, and then we get to the December meeting, then we've got Christmas, and then we're into the middle of January, and that probably doesn't give us a long enough window to develop ideas. So I think if it was okay, if we just take the words "and progress" out, subsequent meeting, if we need to be able to develop an action, we can bring that in later on in the year.
Okay, is everyone happy with that? That seems an acceptable way to me to progress, and December doesn't seem that far away, actually. Sorry, you okay? Yep, okay. So that is, we accept recommendation 1, accept the overall projected financial position of the IGB, and with the amendment of recommendation 2 to delete the 2 words "and progress" from that recommendation, and accept recommendation 3, which was scrutinise and note the issues, which I feel we have done, and that there will be another update coming to the December meeting. Everyone happy? Great, thank you very much. That was good. Cool. I shall let that chat commence briefly while we get organised. We all okay? Yeah.
Yes, Chair. It was simply a comment as to whether or not recommendation 2 should also be amended to specifically bring it back to the next meeting of this board.
Well, I'm happy with the addition of that specific instruction. Yes, to bring it back to the December board.
It's a matter for members. It's a suggestion for yourself.
Yes,
Chair.
I saw lots of nods when I was suggesting it. So if we have that stated clearly, that would be great. Thank you. So we've accepted all the recommendations as discussed and amended. Thank you very much. If I can then move on to item 5, which is the Director of Public Health Annual Report. Some of us will already have seen this in other fora. I'm going to ask Emma Fletcher to come in and introduce it. It's such an important document, and I'm assured that you will all have read it and will have noticed the stark contrasts around the health outcomes across Tayside and the increasing issue of poverty as a prime determinant of health. So thank you, Emma, for coming along today. It's over to you.
Thank you, Chair, and apologies that I'm not being able to join you in person today due to NHS Tayside's mid-year review meeting this lunchtime with Scottish Government, but I am very grateful for the opportunity to present this report to you this afternoon. As I've outlined in the cover paper, this is very much to be used as a reference document. It has the key metrics of population health across Tayside compared to Scotland and broken down by local authority and HSCP area. I'm very keen to emphasise this is not the Directorate of Public Health report. So for additional information on all the work that we're taking forward within the Directorate, please do look online at the Standing Committee reports for the Public Health Committee. That's the Standing Committee of Tayside NHS Board. But as I described, this is far wider and far reaching, and I hope this is of use to all partner agencies. The report is publicly available. You can Google it and it's easily accessible. And the key points that I want to bring out this afternoon in relation in particular to Angus is that, as you will see, life expectancy is stalling for men who are living in Angus and decreasing for women. And that is a picture that is being seen across Scotland. So life expectancy, so the number of years that we can be anticipated to live, is decreasing. The biggest population group in Angus is the 55 to 59-year-olds and adjacent age cohorts, and that's due to the increasing birth rates that we had in the 1960s thereabout. So we are also experiencing an ageing population, but the two things are very different. So we're not living longer, unfortunately. Life expectancy is decreasing, but we're also experiencing an ageing population. And as I've outlined in the report for Angus, we're anticipating approximately a 30% growth in people who are aged over 75 between the years of 2018 to 2028. I should flag that that doesn't capture the further increases that we are going to see beyond 2028. So we are going to see significant health and social care delivery requirements to support people as they get older over the next 2-3 decades. I also want to flag the really sad statistic around premature mortality, and we're seeing increases in premature mortality, particularly in the age groups of 15 to 44 in Angus and across Scotland. And in Angus, that's been since circa 2015. As I say, it is similar to the trend for Scottish-wide average, but simply should not be happening. The drivers for this are around substance use, drugs, alcohol, and mental health illness. We are seeing some improvements in some health conditions. For example, coronary heart disease. We've seen a very steady decline in the need for hospitalisation due to coronary heart disease over the past decade and longer, although even that trend is starting to slow. The reasons for that improvements have been around population health, improvements in reduction in smoking prevalence and improved medical care delivery. But those will soon be offset by the increasing levels of obesity that we're seeing, and that leads to increased prevalence and incidence of type 2 diabetes, and that is likely to reverse the trends that we are seeing in terms of that decrease for some health conditions like coronary heart disease. In terms of type 2 diabetes, there were 1,600 new cases diagnosed across Tayside in the last year, and 90% of those would be type 2 diabetes and potentially avoidable. And also, I just want to flag that the age at which we are diagnosing people with diabetes is reducing. So people are having iller health at earlier ages. Approximately 1 in 16 people across Tayside have diabetes. And as you see throughout the report, there are widespread discrepancies due to the impact of health inequalities and socioeconomic deprivation. And alongside the emerging huge concerns around diabetes and the other challenges around substance use, mental health that I've mentioned, we're also very, very aware and have huge concerns about the impact of vaping on future health, particularly in the younger populations, and very sadly, the impact of climate change. As I've said, determinants of health and the environment we live in are the most significant drivers of health and well-being. But that doesn't mean that we can't impact through the work that we each deliver on a day-to-day basis. We can impact behaviour change through our interactions with patients, the public, colleagues, friends, through advocacy and policy with partners locally and nationally. And I would just remind that promoting health, the environments, prevention, early intervention, as I think Jill described earlier, is realistically the only way in which we can ensure sustainable health and social care into the future and good population health in Angus and across Tayside. Thank you.
Emma, thank you very much. That was a really good summary of the content of your report, which contains statistics that we should all be really, really concerned about. Open it up for questions now for Dr. Fletcher. Gail would like to come in.
Not a question, Dr. Fletcher, more a comment, but I think particularly after the tragedy of Storm Babette this morning, I think it's more important than ever in Angus to prioritise health, well-being, quality housing, etc. that's referred to throughout your report. And I know that you and the team are going to play an active part in the recovery phase, so thank you for that.
Thank you very much. And Councillor Meakin.
Again, a comment, going back to something Gail said earlier, that our planning has to be based on data, and this is a lot of real quality data that can be used for future planning. Thank you.
Oh, Dr. Clement.
Colleagues, we can't hear anything online.
Oh, sorry, I'll start again. It's for clarity, on page 55 of the papers or page 6 of the report, near the top, teenage pregnancy rates states in Scotland are 27 per 1,000 females, compared to 38 in Angus and 30 for Dundee. When we look at the graph later on, I think that is the wrong way around. I think that we are at 30, and I notice on the graph that's on page 94 of the papers or 45 of the report that it has flatlined in Angus. I'm very aware of the association between deprivation and teenage pregnancies, and I'm seeing the increase in termination rates in Tayside. I just think it's worth highlighting the importance of sexual health service, which is obviously hosted in Dundee, and it is a concern for me around access to contraception for all our women in Angus, but particularly around the young, and that's impacted by COVID, impacted by the sustainability of primary care, but also that we don't have the level of sexual health or family planning clinics within Angus that we used to. And just to highlight, we are taking that forward with Dundee Health and Social Care Partnership around how we might explore looking at that particular issue. But it's just making sure that that was clear around the discrepancy. Thank you.
Thank you, Alison. You preempted me. I had that highlighted as an issue to pick up, so well done and thanks. Emma.
Yeah, no, thank you. As you can imagine, there is a wealth of information in this report, and it has been to several committees already. So again, all credit to the Hawkeyes, and I'll get that amended. And thank you so much again. Apologies for that.
Catherine Lindsay.
Thank you, colleagues, and thank you very much, Emma, for the report, which was really interesting and insightful. I'd like to make a connection, if I can, at this point in the agenda, today's proceedings, to item 13 in the Chief Social Work Officer's annual report as well, which I think reflects a lot of what Emma has outlined in her report around the consequences of poor health and inequalities across our communities. And we're seeing that in terms of increase in need presenting at the top end in terms of social work, both for adults and older people, but also for children, children who are the children of parents who are adults who have qualities throughout their lifespan. I think the report quite rightly highlights in the executive summary the particular challenges in Dundee, and I don't think anybody in this room or in this online space would disagree at all that we know there's a significant concentration of deprivation and the associated poor outcomes for people in Dundee City. I suppose from an Angus perspective, and just building on Alison's point of earlier, I am concerned though that within that there's a risk that the deprivation and the experience of individuals who are experiencing poverty in Angus and much more communities becomes less visible within that space and that discussion. And Alison's quite right to point out, Dr. Clement's quite right to point out that accessibility for services for people who live in Angus and are rural, but also in our townships, it is much more challenging. And I'm just wondering, Dr. Fletcher, whether there's anything in terms of the analysis that you would highlight to us that we could do or consider both within the Health and Social Care Partnership, but also the constituent organisations across Angus and Tayside to address the imbalance that people in poverty would experience in relation to access to care and support.
Thank you. If you can come back in, Emma, on that one.
Thank you, Chair. And yes, I completely understand that the challenges of presenting data for 3 local authority and HSEP areas within Tayside. I think I'm very keen to, and have hopefully strengthened in the report in terms of that Scottish-wide context in UK and the Western countries. So I absolutely do not want to take the Scottish average as the benchmark where we want to get to. It is there for each area to understand, to use as a baseline, and also each area will have their areas of particular challenge, and absolutely Angus and Perth and Kinross will have challenges around rural deprivation that are not as present within Dundee. This report sets out the challenges at a population level, and then each area really does need to drill down and take that to understand in greater granularity what that means for service delivery, the health of their population areas. I think what I'm really keen to strongly emphasise though throughout is that there are challenges, and we need to be focused on those in every interaction. And for example, as a clinician, kind of thinking back to the impact that we can have when we engage with patients, and the power of that cannot be underestimated. So it is that every opportunity, I would just encourage people to be focused on the context and the challenges in which we are living and working. And if we have any opportunity to influence at an individual, community, national level. These are the particular challenges that we face, and I will take this opportunity to remind colleagues that Scottish Government are currently outpricing a wealth of information, and I would encourage people to go online and have a look at that and participate if they feel that they are able to. Thank you.
Thank you, Emma. That was a good plug for that consultation. And also, as a bit of an aside, through the IGB Chairs and Vice Chairs network throughout Scotland, I'm the Vice Chair of the subgroup on remote, rural and islands. So we're currently looking at significant discrepancies that affect our own areas, but how that all works together as well, to look at how we can address those. So timely discussion. So Councillor Speed now.
Yep, thanks, Chair. Thanks, Emma. Yeah, a lot of really concerning statistics within that report. But I just wondered if you could talk a little bit more around the impact of long COVID. I don't really see much reference within the report with regards to long COVID and the impact that that's having, and also those that have experienced adverse reactions to the vaccination.
Yeah, thank you very much for your question. So our understanding about long COVID continues to evolve, and clearly it has significantly impacted a number of people following the pandemic, and continues to as the virus is still kind of circulating, and people will still be impacted. I think for me there is, so I think there are two things. There's firstly in terms of how that significantly impacts population health, and whilst it absolutely does for some people, not at the levels that we're seeing impacted by substance use, mental health, and other public health challenges that we have at the time. That doesn't mean we can forget about it. And I know that there's a lot of work going on around provision for long COVID. What I would like to see, though, is that being in business as usual, and the support and the facilities being there for anyone who has a post-viral illness and syndrome, because we recognise that it's not just people who have long COVID post a viral infection that are impacted. So it's about making sure that we have all those resources available for anyone who is experiencing a long-term condition. It's not unique to long COVID, although I appreciate the concerns arising from long COVID. And I'm also very aware that I've got clinical colleagues, Scott, Alison online as well, who may want to input into that also. And Councillor Speed, I'm so sorry, I've forgotten your second question and I put it down.
It was in relation to adverse reactions to the vaccination. There doesn't seem to be much kind of detail or reference to that.
Yes, I mean, the adverse reactions data is published nationally by MHRA, and there's again, it's not prevalent at population level, but adverse reactions tend to be incredibly short-lived, self-limiting, and there was very extensive monitoring of the vaccination rollout in the initial months. But the safety profile of vaccinations and the benefit they confer are really immense. Now, I know that again, a small number of people have been impacted, but I cannot understate the beneficial impact at a population level. So again, in the context of all the possible health conditions that we the limitations of trying to get everything into one concise, relatively concise at 75-page report. I hear your concerns. I can provide additional information to that separately, but it's not the major public health challenges that we're facing. And overarch, I really do want to emphasise the strong messaging about the benefit of vaccinations.
Thanks, Emma.
Thanks, Emma. And Scott Jameson's got his hand up. Scott.
Thank you very much, Councillor Bell. Thanks, Emma. Scott Jameson, I'm GP, the Associate Clinical Director, and I sit on one of the national long COVID clinical advisory groups, and I also sit on the local long COVID advisory group as well from a clinical perspective. Just to reassure that it's definitely not definitely not out of mind, and I think Emma very eloquently describes there what our theory underpinning is, that absolutely we probably slightly underprovided pre-COVID for rehabilitation post-viral illnesses and post-significant illness, and certainly we need to make sure that we are clearer on the pathways to do that. We do have a local pathway for this, for which we're just revising a couple of little tweaks just now, but it's definitely available and circulated, and we're going to recirculate it just to keep that fresh in the minds of colleagues as to where they can get those avenues for support for those that are burdened with post-viral and other things. But absolutely, as Emma alludes to, got to make sure that we focus on provision for all long-term conditions and all ongoing things through prevention, proactive care, and making sure that our systems and our pathways support action. So it's definitely not something that is a good lesson for us to remind us that sometimes not everything can be cured, but sometimes we can provide other things to support, even if we don't have a single medicine or a single treatment for it. There's still other things that we should be doing as a health service. But Dr. Fletcher's comments as well.
Thank you very much, and it might be useful, Lois, if you want to go and check out the Chest, Heart and Stroke Scotland new strategy, No Life Half Lived. Chest, Heart and Stroke includes long COVID in their family of conditions. And just today, actually, social media, I saw the NHS Tayside allied health professionals promote some joint activity with Chest, Heart and Stroke to support people with long COVID. So there is certainly lots going on locally to support people in their recovery. And those partnerships with the third sector organisations are so important that allow people to move through the system on their recovery with highly specialised support. And the outcomes for people who do work with Chest, Heart and Stroke models of care. So that's your recommended reading for the weekend.
That's the best update that we're including, Dr. Councillor Bell. That's exactly the thing we're going to include. So yes, that was the bit that's coming in. Thanks so much for highlighting that for us.
Thanks, everyone.
Thank you. And Andrew.
Thank you, Chair, and just to echo others, thanks to Dr. Fletcher for this most important, although uncomfortable to read, report that highlights these key things. I think it specifically highlights the challenge that faces us within really a relatively short period of time as our population age is, and it's an ageing population that we're then looking to provide the care and to provide the support for that population. So it's almost the sort of perfect storm of a sort of population shaping and progression. The pressure is on all of us, and really this should, the paper calls an acknowledgement of the report and continue to consider its content. Should be a backdrop to every single committee, every single decision that we make. It's almost as important as doing an equality impact assessment when you're proposing any changes, to make sure actually you've got a public health impact assessment included with that. And also just to highlight that it's not just macro changes, it's not big population changes. Actually, the most important things are the micro changes. It's the single conversation that I have with the patient about their alcohol misuse, or it's a casual discussion about smoking cessation that someone has necessarily when they're having their haircut in a barber's or something like that. You know, it's these things that actually impact, and we should use this as a focus to further integrate our services as closely as possible. And you know, by definition, we are the working example of that, of health and social care integration. But actually, the more integrated a service we have, the more impact we can have, and then easily be linked, and we can signpost people easily through the system to enable that change to happen. So very much support this, and very much support this being seen as really core reading material for every group and every committee that we form.
Thank you, Andrew. I couldn't agree more. It needs to be the go-to all our strategies and policies, and checking in on the difference that we can make every time we do something. Does anyone else? Jill would like to come in.
Thank you, Chair. Just a proposal, if I may. I'm just wondering if we should include public health implications as a section in IGB reports, so that when we are bringing reports forward, we're taking into account and consideration the public health impact of that, and if that's something that IGB members would find beneficial.
I'm loving that. I think that would be excellent. If everyone else think you'd have any resistance to that, thank you very much. I think that would be really helpful as we progress anything at all. So let's go back to page 47 and the recommendations. If there's no other questions, I'm not seeing any hands. Thank you so much, Emma, for coming along today. Really appreciate that. And I know these are conversations that are happening in lots of different forums and groups, so it's not a one and done, far from it. And I hope you take some significant comfort and confidence from Jill's proposal around how we, in terms of our governance. So can I ask the board to recommend accept the recommendation in the paper, to acknowledge and support the report, and to use it to inform our strategic planning and work? Yes, that's super. Thank you very much indeed. And Emma, if you are needing to go, please feel free to do so. I know you've got a lot of time precious today. Thank you very much. So I've written down. Sorry, I've getting page numbers popped. I've written them all down myself. Thank you. So if you can move now, and I think that will be Jill at the table to speak. Thank you.
Thank you, Chair, and I'm delighted to be in a position to bring a progress update in relation to the development of the Tayside Primary Care Strategy. The development of the strategy is a collaborative effort between all three health and social care partnerships and NHS Tayside and wider colleagues. The purpose is really around how we support and enhance primary care services across Tayside and ensure that they are excellent, they're high quality, they're accessible and they're sustainable. So just picking up on some of the conversations earlier around sustainability. So members will be aware that Angus IGB has the responsibility for the strategic planning and coordination of that strategy around primary care services. And one of the things that we're really keen to look at is how it aligns with the National Health and Wellbeing outcomes and indicators as well, hearing the importance of that prevention, the proactive care. Primary care is absolutely essential for local communities and plays a really critical and crucial role in health and care systems. But we know about some of the challenges that are ahead of us from a workforce perspective. Across a number of different professions, as well as the increase in demand, and we heard about that in the finance report when we were speaking about the large hospital set aside. We are really wanting to take a joined up approach to this. So we had an initial session in August with a number of different key stakeholders to look at how we could pull together their thoughts, their ideas, and that's what's informed the plan on a page, which you do have in front of you today. It aims to really promote proactive and preventative care, community-based health and wellbeing. I'm going to say person-centred care, but just hold that thought for a minute, and efficient resource utilisation. The first principle of the strategy is around care, but actually as the discussions are moving on nationally, it's around that person-led care and how we can support and develop the person-led approach to that. I'm not going to go through all of the different principles in the strategy. They are there for you to see on the page. Another really positive step that has taken place is a really excellent, and Sally might want to come in, a meeting with the public partners from NHS Tayside, just to really go over the plan on the page, the thoughts, the direction of travel, etc. And it was a really enlightening session with the public partners. And as it is, the plan on the page that you have in front of you has changed quite dramatically, not so much in terms of content, but in terms of layout, and that's based on what we heard from some of the public partners. I do have a hard copy here that I can, but one of the things that they emphasised was the importance of communication and for them knowing how to access it, knowing where and when they could access support in the signposting. So from an Angus perspective, the strategy, and we are hoping it comes back in February for approval, we will look at how we implement that in Angus, what that means for us as a partnership, taking into account our local implications around that strategy and what it actually means for us. How do we make it meaningful? And the other thing that we would quite like to do within the paper is a development session, and as part of that pick up on some of the content that Andrew and Alison were alluding to around the sustainability. So what is the primary care picture in Angus for IJB members? So it was discussed at Dundee IJB this morning. I know Susie and Donald were at that IJB as well, and it was supported at the Dundee IJB in terms of direction of travel. So thank you, Chair.
Thank you very much, Jill. I know Peter Davidson has his hand up in the room.
Certainly, thank you. Thanks again, Gillian, for the report. Really interesting. It's clearly a really challenging area. We've got it's an older population, and our patient to GP ratio is obviously not where we would want it to be, and I can't see it improving anytime soon. I think this is a really good plan, particularly the plan on a page. I suppose what I would like to see with any plan is, what does success look like? You know, when we review this strategy in a few years' time, what's going to be our success? I get that it's outcome focused, but I'm just wondering, I suppose, which KPIs we're going to be defining success with a plan like this. Is it health outcomes? Is it patient satisfaction? Is it a bit of all of the above? And I note that there's another report coming back that may have more detail on this. So thanks.
Thanks, Peter. Jill.
Well, like just in true Blue Peter style, here's one we made earlier. So this is the new layout, and it does at the end of it say, how will we know that we've made a difference? And that includes the indicators. So there you go. Answer.
Yeah, thank you for that question. It's good. It's good to see that.
That's just the changes from.
Yeah, looking forward to seeing that. Gail wants to come in next, please.
Yeah, this is one of the frustrations for myself, actually, I must confess, because I had really hoped that the primary care strategy would be presented at this meeting. To add there, so I'm so sorry that we haven't been able to do that, but I'm leaving it in very capable hands that this will be progressed. As Jill said, it went to the Dundee IJB board this morning and the progress was supported. It will also go to the Perth and Kinross IJB later this week, so I'm hopeful that it will be supported there. We also take regular updates to our Care Governance Committee, and I privilege Teesside Risk Committee as well. I would also pay thanks to Audrey Lindsay and the Public Partners Group for prioritising this for us around communication, because as Jill says, it's really important that we get this right and we go widely with communication. Traditional smaller groups, and we really are looking to make improvements based on some of our other previous updates on communication and suggested improvements. By way of one positive point as well, I would like to confirm the appointment of Dr. David Shaw to our Associate Medical Director for Primary Care, and David has taken up post now. So that's definitely a positive move. We have a number of outstanding areas from the audit report, but they are all in train. And as Jill said, I think we're definitely making progress despite sometimes it appearing slow in some areas. So thank you.
Thank you very much. As someone who was involved in the primary care strategy at the turn of the century, here it is again. But I don't want you to think of it as failure for you, Gail. It's delayed success for your team.
Thank you.
Alison.
Thank you. I just wanted to come back around the key performance indicators. We do have quite an extensive piece of work which Scott Jameson, who's on the call, has done around the sustainability of primary care with a matrix across several indicators, and we are fortunate to have all Angus practices, and the vast majority of Tayside practices have contributed. And that does look at workforce, it looks at various things related to workforce, and also the patient experience surveys, the national surveys, and so that is able, when we look at it, to give us triangulation of data in terms of how practices are doing, and that aligned with what our practice, the intelligence we have within the health and social care partnerships around. Gives us quite a lot of good information. So I guess when we're looking at how will we know when we've improved, this matrix that we've got does give us a way of monitoring across practice. You'll understand that some of that information have practices giving us very open and honest about how things are for them, but that does allow us to see over time, and high-level data would be made available. So that will give us quite a lot, and it's been an extensive piece of work, very helpful, and hopefully that will help us monitor how we're doing.
Thank you. Jill was wanting to come back in there, but I'll hold that thought.
Thank you, Chair. I think that's exactly what we were proposing to come in the development session around primary care, that level of detail. I think just the other thing to highlight is the primary care strategy won't just be around general practice, it's all primary care services, so it's all of our independent contractors as well, so just important to know it's not just around GPs.
Important to be clear on that, thank you. Peter, did you want to come back in?
Oh, just briefly, yeah, thanks for that additional detail. The patient experience concern worries me always, because I think it sometimes skews it doesn't share the really good work that's going on in the positive stories. I think folk are far more prepared to share the negative experience that they may have. So how good are we at capturing the good news stories from patients too, so that there's a good balance?
So indeed, that is very challenging. We have within our other services care opinion, and we are fortunate that we have our 2C practice now engaging in care opinion, so that will hopefully give us some information. But absolutely, I agree with you. We need to be doing more of that. Thank you.
Jill's asked to come in, and I see Lewis and Scott in the queue. Thanks.
Thank you. A really interesting point, Peter, because when we met with the public partners, I think the communication part of it is so important. So what does primary care mean to them? And the negativity in terms of some of the complaints that they were raising, it was actually around their expectations. So they expected to see a GP. It might be that a GP wasn't the most appropriate healthcare professional to see that individual at that time. But there is a perception out there from the public that they expect, if they phone their doctor, they expect to see a doctor, not an ANP, not a pharmacist, or physio if it's first contact physio. So there's something around the communication that we have, and that's how it's so important as part of the development of this strategy that I know Gail's referred to it as a failure, and it absolutely isn't, because I think delayed success is a great way to describe it, Julie, because it feels as though we've had to take a few steps back to take that leap forward, to be able to truly understand and engage in a meaningful way, to get the strategy completely landed right and meaningful for the population of Tayside, because it is a Tayside strategy, but also then what that means for Angus. So expectations, public expectations, are going to be so important throughout this whole journey.
And that also ties into the public's role in their own health and how they contribute to that whole picture. Lois, I'm going to ask you, is your question on the same thing? Because it might be that Scott wants to come on that particular thread.
Yeah, Scott, I'm happy for Scott to go, no problem.
Thank you.
Thanks, Councillor Tracy. Thanks, Chair. Just to highlight, as Alison alludes to, so health and care experience does pick up some of the positivity stuff. So the more positive you are, the higher it will rate on the bits that we're capturing out there. But equally, for care opinion, it is the National Clinical Director, Jason Leach, has said to have equal access to care opinion across Scotland. I have met, and we have met as a local team with the National Care Opinion team to scope out the viability of this, because it would need some tweaking to be viable within general practice. You might go to an outpatient appointment or a hospital appointment once a year, but there's people that attend their GP 30 times a year, and every time they go, to have a care opinion feedback would be lovely, but it would be quite overwhelming because we like to respond to them. We like to respond to care opinion feedback. So we have to tweak it slightly, but it is something we're exploring. Funding needs to come with it naturally to make that viable, but it is absolutely something that we're interested in, because absolutely have good experiences with their healthcare providers, and that sits for care opinion as it stands now. I think 60 to 70% are positive, and areas for change, ideas for improvement is definitely something we're interested in capturing equally. So, but thank you for highlighting, and I'll make sure that we keep the IGB briefed on it if this is something that comes to fruition.
Thank you. And Gail's trying to jump in front of Lois there, but I haven't forgotten you.
Sorry, Lois. I'm just remembering here a piece of work that we did with multi-professional teams way back in Latham in Angus, where our Latham population were, as Jill said, focused on seeing a GP. And Dr. Thompson and I were both involved in that at least 10 years ago. We had to do an immense amount of work with the population of Latham, and we really took it right down to some of their development days that they are in Latham. The Dempster Day springs to mind, where we were really supported with the community, working with them around how we really looked at population needs in a different way. So I think there's just a lot of learning locally we can also use.
Thank you. And Lois, and I do apologise, it all ran together in the same thread.
It's quite all right. Thank you. Yeah, I do always welcome seeing a strategy or a plan on a page, and I think it makes it very clear and easy to look at and follow. Just with regards to the equality impact assessment, again, I always welcome when it does recognise the positive and the negative, and it does, when an impact assessment does give recognition that there may be an impact, especially if there was to be a shift or change in a resource. But I couldn't quite work out just what kind of the negative impact was, or the impacts were. There is some reference to digital, but again, it's not very clear in what the kind of mitigating kind of actions will be to try and change that.
Okay, thank you. Jill's picking that up.
Thank you, Councillor Speed. And interestingly, that was a question that was asked at Dundee IJB this morning as well in relation to that. The plan on the page is just that, it's a plan on the page. We have to do an extensive piece of work still to pull the actual strategy together, so we don't know the detail of every single thing and every negative or positive impact that this strategy may have, and that will be, I actually think it's really positive to have an EQIA at this stage, because traditionally we wouldn't, but this is our first time of testing it as a kind of document at the front of a development of a strategy. So I think as we progress, Councillor Speed, and we get more detail, then we'll be able to add the mitigating actions into that, because we'll have a better understanding of exactly what the positive and negative impacts actually are.
Thank you. I'd like to bring Andrew in there. Thanks.
Oh, that's great. Thank you, Chair. And my thanks to Gail for reminding me just how years pass far too quickly, because I was just casting my mind back, and I think, unfortunately, it's approaching 15 years since the first discussions in Latham. I think, Jill, you've highlighted two very key things within this. Firstly, this is absolutely primary care. This is not general practice. This is not just dentistry. It's the widest part of primary care. And even when you focus on general practice is no longer delivered by just GPs. It's delivered by a very wide multidisciplinary team. Some of that multidisciplinary team has been in place for as long as I can remember, such as my district nurse colleagues, etc. But it also includes social care colleagues who are providing significant amounts of care, significant amounts of information and insight into a person's health on a day-to-day basis, and linking that up so the priority for putting more work behind enhanced community support is absolutely critical, and I know that's picked up in a further paper on today's agenda. But communication is also important, and communication won't be successful if it's just in Angus communication. This is not just even Tayside communication, but it's ensuring that we use all of our connections out with Angus to ensure that the public messaging isn't that messaging of see your GP. We do need to focus on the right care, right place, right person type discussions and signposting for patients, so they don't come to a GP practice expecting to see a doctor because they've already recognised the fact that actually there is a wide gambit and they will be signposted to the person who can best cater for their needs at the time.
Thank you, Andrew. Anyone coming in? Any extra?
Just in relation to the wider communications, I think is again something that came up at the public participation group, and we do have to align with obviously the national comms around this, but we are trying to explore how we can inform and potentially influence some of that national communication. So that, and I know comms and engagements on the strategy, Sally might want to come in a bit more, but it is really important, and we are different to other areas, and I think it's recognising that, because across Scotland we do our services differently, so that message is even more important for us because of the way that we deliver the services.
Okay, thank you very much. Does anyone else have any more questions? I'm not seeing any hands up, so can we go back to page 128, please, to look at the recommendations. Acknowledge the progress made to date to prepare the Tayside Primary Care Strategy, and agree that a final version of the strategy will be brought to the IGB for approval in February next year. And to add to that, my thanks for Jill and all involved in taking that forward. That workshop in August was actually really helpful. I was part of that, and I think that's a really powerful way of engaging people and getting to a place where things do move forward. So all the best for that. Thank you very much. Okay, you want to come in at the end?
Just to pass thanks on to Sally and our team for the work in coordinating and pulling it together, and the design as well of the new plan on the page, because it is exceptional, and the wider primary care team too. Thank you.
And I look forward to getting that new plan out. That would be great. Thank you very much. So if we can move on to item 7 now, which is the category 1 responder and resilience planning update, which is pretty timely, really, Jill. Thank you.
Thank you. So yeah, Chair, timely in relation to the experiences last week and the fact that we now have another yellow warning for rain that's come out for tomorrow over the weekend. So yeah, again, I think this was a planned report. It's not just as a result of the goings on. So this report outlines the IJB's status as a Category 1 responder in the context of the Civil Contingencies Act 2004. I thought the screen had just gone blank there. And it describes the responsibilities and the obligations and implications associated with how prepared we actually are as an IJB to fulfil this role effectively. The Act itself provides a framework for the key public bodies, so ourselves, NHS, Count, local authorities, etc. But they also have key utility providers as part of that response as well. They're classed as Category 2, and it defines the responsibility of each individual partner in relation to an emergency. We were designated as a Category 1 responder in March 21, and that was quite a shift for us as an IJB, and I know that there was a development session not long after that just to raise awareness around that. So the paper describes the core responsibilities of a general Category 1 responder. We've tried to describe the work that we've been doing in the background to increase our infrastructure around our preparedness to respond, but have that as a long-standing kind of sustainable structure to be able to stand up, stand down when any emergencies arise. So we have been doing a lot of work over the last few months through Abby and Fiona and the team to get to a point where even just reflecting, we do have a formal debrief tomorrow, but reflecting on how quickly we were able to stand up last week within, I think, 2 hours of the regional discussions around it, we were able to stand up our incident control and ensure that we worked with key partners to be able to respond in an effective way. So I'm not going to go into any more detail. I know the appendices are really, really detailed. We haven't put any direct financial implications in the report, but in terms of the impact of incidents, and I know that that was something that you picked up earlier, Councillor Bell, we're never going to know that. So in terms of being able to put a kind of pound sign around our status as a Category 1 responder is quite challenging. So we also have our development session coming up on the 15th of November, which is in relation to Category 1 status. Part of that session will be around looking at it as a potential risk, whether it is a strategic risk for us or not, or whether we have undertaken enough work in terms of the mitigations and the controls, and that will be mapped against our risk appetite as well going forward. So there will be a lot more detail at the development session on the 15th of November.
Thank you. I think the pandemic triggered a realisation that there needed to be a review of who was a Cat 1 responder, because not even Public Health Scotland was, and we had to go through that process there as well. Anyone have any questions around this particular paper? I think it's incredibly thorough, all-encompassing, and like many emergency responses, it reflects in time because you don't know what you've missed out and missed it out. But it's pretty thorough, and it's consistent with other parts of the system. And again, I just want to commend everyone for pulling the rabbit out the hat again at the weekend. People just know intuitively, don't they, what they need to do, and it's the right thing for the citizens that are facing such incredible trauma. Lois.
Yeah, thanks, Julie. Thanks, Jill. I just wanted to kind of touch on, I think, point 4 within the report, page 156, in terms of public communication. And it states transparent and timely communication with the public during emergencies is essential to mitigate panic and provide accurate information. And I just wondered how the partnership will manage this, particularly in reaching out to our most vulnerable, where, you know, we already recognise that not everyone can access the internet or are able to easily access kind of supports and the resources that might be out there.
Thanks, Lois. Jill.
Yeah, thank you, Councillor Speed. I think public communication is and depending on the nature of the incident that are being dealt with, one of the Category 1 responders will take the lead in terms of that wider public communication. So whether that be Police Scotland or indeed Scottish Fire and Rescue, Scottish Ambulance Service, depending on the nature of the incident itself. In terms of our internal communication and how we communicate with service users, there's a variety of different methods that the teams will use, and they will know their own service users and how best to get in touch with them and how best to describe what's actually going on so that they can understand the situation and understand what it is that they need to do in relation to that. And that could be a phone call, it could be a text message, it could be door knocking, it could be different things for different services to be able to ensure that we can communicate and get in touch with our vulnerable, not just our vulnerable service users, actually our service users as a whole.
Thank you. And on that note, I'm just flagging up a warning that the weather outside is deteriorating quite badly, and we've had flashes of lightning and rumbles of thunder. So just in case our power goes off, so you're aware, in case, and in that case, we would probably need to reconvene the IGB at quite short notice, which is not a situation we want to have to consider, but just hold that thought, okay? And after this paper, I'm going to suggest we have a short comfort break for 5 or 10 minutes, because we're rolling up to 2 hours now, and I'm aware that people might be getting a bit fidgety. So after this paper, that's a technical term. Any more questions on our Cat 1 paper? Nope, I'm not seeing any. Thank you. Okay, so I'm asking you to recommend that we acknowledge the work undertaken to ensure that we can fill the duties of a Category 1 responder. And I think we have the evidence of that just in the last few days. So I'm not seeing any dissent from that, so that's great. Okay, so that's approved, and it is now 3:49, so I'm suggesting we come back. Are you wanting to come in?
Okay, sorry, just to say thank you to Fiona and the work that Fiona and Abigail's done in relation to leading up the resilience work.
Very thorough, thank you very much. So is 5.2 okay for everyone? Yeah, we just come back at 5.2, please. Thanks very much. If by any chance you come back and there's no sign of anybody, you'll know what's happened. And Donald, you always look so cheery there.
Sandra, if you could stop the Sandra, if you could stop the recording just now.
Okay, are we ready? Yep, that's us. Welcome back, everyone. Sorry about that additional delay. Just everything that could go wrong is going wrong. So if we could move now to item number 8, and we have Sally here to go through the communication and engagement update and strategic framework. Thanks, Sally.
Thank you very much, Chair. So this paper provides an update on the communication and engagement activities of Angus Health and Social Care Partnership from October last year to September this year. And we also present the refreshed communication and engagement strategic framework. So first of all, I'd like to really take the opportunity to thank NHS Tayside and Angus Council communications team who continue to provide invaluable support to our communication activities. And we've also recruited a new post in Angus Health and Social Care Partnership to support communication and engagement activities. So that's a huge support to me and the Improvement and Development Service. And I hope that you'll see a number of significant improvements in relation to communication and engagement as a result of that. We've spoken already today about care opinion, and since the publication of the papers that you have in front of you, the total number of stories received has increased to 187, and these have been read 21,341 times, so quite an increase, and 98 stories since April this year. The refreshed engagement strategic or communication and engagement strategic framework aims to raise awareness of Angus Health and Social Care Partnership and the work that we do and build on our reputation. And we work hard, we really do work hard to listen to the voices of people living in Angus, but we know we can do more. We know we need to do more, and really not only to encourage people to engage with us, but to enable people to engage with us. I very much hope that you have read the framework, and in addition to asking members to acknowledge the progress made over the last year, I'd like to ask members to approve the strategic framework and action plan and suggest that we have communication and engagement as a section within the relevant IJB reports. And this will improve members' awareness of the activities that we've undertaken and inform papers. So that's all I'd like to say. Thank you.
Thank you, Sally. Anyone have any questions for Sally? Peter Drury.
Short one on care opinion, which I've long been a fan and supporter of. Has take-up on that levelled off?
No, increasing. We get regular stories, and I think the fact that we've had 98 stories since April is telling in itself. I should say the majority of stories are positive, they're very positive, and they have a huge impact on staff. It really does encourage them, and it's really powerful, the impact that has. So I don't think it has tailed off. Do you mean the number of people who are responding? Yeah, no, and we're widening it out and promoting it. We have a dedicated person within the Improvement and Development Service who's doing that.
That's good to hear. I remember when I was freshly on the NHS board, I had asked, how do I make a favourable comment? And the answer was, you go to complaints. And then, of course, you give up.
Well, even in the council, Peter, it used to be complaints, and I know I had requested quite a few times to make it possible for compliments to go in, because people need to see that balance, and it is actually working really well. So whether it's a compliment, a comment or a complaint, people need an opportunity to feed that in, and I think that's really important. Lois.
Thanks, Chair. I've got a few questions. Will I just give them all at the one time, or do you want me to break them down?
Just go on and give them all in one go, that'd be great.
Okay, thank you. So with regards to page 205, Engage Angus, and the digital platform, a lot of confidence is needed, especially from those that find it more difficult to engage and take part. And I just wondered, what other methods would there be for people to input who are not online, and what support will they be, and who will provide that support for those that might need it? And also in relation to page 206, there is reference to legislation that needs to be considered within the strategy. However, there's no reference to British Sign Language Act. I just wondered if that can be included, and what communication and engagement is there for residents within Angus who require British Sign Language, and how are we engaging with them? And is there any plans within to provide BSL recorded messages and meeting opportunities, especially when there's key consultations and community input that might be needed on decisions that are being made? And also on page 207, it talks about engaging and empowering people and helping them to claim their right. I just wondered how that will be managed when there are increased pressures. The report talks about kind of difficult decisions that will have to be made. So I guess my question is, will the Health and Social Care Partnership really be able to help promote and promote people to exercise their rights when there might not always be the resources to uphold them?
Thank you, Lois. I'm passing over to Eunice McLennan for that.
Thank you, Chair, and thank you, Councillor Speed, for your question. So you'll be aware that in Angus we have a sensory service, and one of the key roles of that service is to help ensure that those with visual impairments and communication and hearing difficulties are aided with communication. This includes interpreters who interpret through British Sign Language and are active within the Angus area and work currently with over 40 people who have hearing impairment. We also have NHS Tayside also have a facility for people who have hearing challenges that they can access for responsive support, accessing phoning your bank, phoning up about your mortgage, whatever it might be. There is a facility that they can engage within that. And we also have a national 24-hour helpline that people can contact that they can be used. So there's quite a lot of different facilities available for people with hearing impairments that people can access in Angus. Thank you.
And Sally now, thanks.
Yeah, Lois, thank you very much for your question about Engage, the Angus Council platform. That's just one tool that we have. You'll maybe remember that when we were engaging about the strategic commissioning plan, a number of us went out to supermarkets across Angus and asked people to engage with us. I have to say that when we distributed over 90 questionnaires at that time, and we only got one back. So it's really quite interesting that we do go out and talk to people, but we cannot make them. We probably made people more aware, but if people don't want to give us information back, it's really quite difficult. So, so we will be going out and about and talking to people. I had a very interesting conversation last week about how we can really further our engagement with the Gypsy Traveller community and work with the delegated officer in Angus Council to help us to do that.
Okay, have you got any follow-up, Lois?
Sorry, yeah, I think there's echo. That's better. I think there was maybe a bit of confusion around my question around the British Sign Language. What I was saying was there's no reference within our own communication strategy and plan. So I'm absolutely aware that there is services and supports there for people, but my ask is, what are the partnership doing in terms of their communication and engagement strategy and plan and their ways of engaging with the deaf community?
Okay. So thank you very much for highlighting that wasn't referenced, and I will make sure that is referenced within the plans.
Thank you.
Okay.
And I don't think my final question was answered around promoting rights.
Could you elaborate on that just a wee bit more, please?
Yeah, within the strategy on page 207, it talks about engaging and empowering people and helping them to claim their right. And my question was around how will the partnership kind of manage that when there's increased pressures, and the report talks about difficult decisions that might have to be made. So I guess I was asking, will the partnership really be able to help promote people to exercise their rights when they might not always be able to provide the resources to uphold them?
Okay, thanks for that, Lewis. I'll go over to Eunice.
Thank you, Chair. It's just to offer some reassurance that we are a person-centred partnership, and one of the things we spend a lot of our time doing is listening to people and ensuring that their rights are protected and promoted. And I can think of a number of examples recently where we have had these debates. We've gone to the Mental Welfare Commission, for example, just to make sure that we are promoting people's rights. We look for external advice as well as looking within our own resources to make sure that at all times the decisions we make for the people of Angus are ensuring that we are upholding people's rights. Thank you.
And just this morning, I was, I guess, not a witness is too strong a word, but a contributor to a meeting with a UNICEF colleague around the Silver Award for Isla Primary School as a rights respecting school. And these are conversations that we can all have in our day-to-day jobs around encouraging people to think about their rights from childhood up. So I do think it's not down to one particular agency. We all have a role in that. And as elected members, we have a fantastic opportunity to have those conversations with people we engage with while we do our routine day job, really. And I've just had an email from the head teacher to say that they have been awarded their Silver Award. So that was a good opportunity. Thank you. Any more questions around that? Okay, so Sally will pick up that omission from the references at the bottom of the document. And on that note then, if you bear with me till I find the page again, I would go back to the recommendations on page 191, and rather than read them out, I'm asking the IGB to approve all of those recommendations. And I note that we've got two number 4s there. So the last one, if we could edit that to say 5, that would be great. Just a tiny little typo there that jumped out. Okay, so with that, if we can then move on. And thank you very much, Sally, for that work. And we all know that communication is not a one and done, it's ongoing, and there's always ways to look at improving and new technology developments that do meet people's needs who perhaps have particular challenges around accessing information. Sorry, Lewis, is that your hand up again?
Yeah, thank you, Chair. It was really just to pick up on that there. I just wanted to kind of pick up on it's more of a comment really, just around the quality impact assessment. Again, although that it recognises the challenges, it doesn't show that there's like any kind of negative impact that there may be if there was to be resourcing. You know, we know that there's resourcing issues, but it was just around the impact assessment alongside it. Again, just back to that kind of digital exclusion that some people experience. Just wondered if it could be kind of highlighted a bit more. Thank you.
Well, I think our earlier conversation highlighted that, and I think that will be addressed in the practicalities of how we engage and communicate with people. So thank you for that, for emphasising that. Okay, thank you very much. And if we can move on to the next paper, which, bear with me, is the Angus Urgent and Unscheduled Care Programme and Winter Planning Update, and it's Jill Galloway. Thanks.
Thank you, Chair. Again, really happy to be bringing this update in relation to some of the work that has been going on regionally and within Angus around urgent and unscheduled care. And it is that time again where, although it feels as though not weather-wise that we may be working in winter all year round, but in terms of the demand on the services. But formally we are approaching the official winter period, and that means that we do have to undertake certain pieces of work and bring inputs to the IGB. So the report itself provides an update to the IGB on the urgent and unscheduled care programme in Angus, and it also outlines its alignment to the wider regional work and indeed the national work. The national collaborative is aimed at delivering the right care in the right place at the right time, and that's something that we've heard throughout a number of different papers throughout today's meeting. It focuses on care closer to home, virtual capacity, discharge without delay and community-focused integrated care. And we have in Tayside 5 strategic priorities to support these changes. Within Angus, we initiated our urgent and unscheduled care programme just over a year ago, and members may be aware that we did bring a paper at that time suggesting and proposing that we take a quality improvement approach to urgent and unscheduled care in Angus, and I think the feedback from the last year has proven some of the benefits of taking that approach within a service area and not specifically coming and saying, here's the new model, here's what we want to do. It's very much an iterative process, looking at data, looking at the impacts, looking at the outcomes of what we do. So the paper outlines some of the work that has been ongoing within Angus. There's a few areas of work that we are looking to progress over the course of the next year. In relation to winter planning, as I said, on an annual basis, we have to prepare traditionally a winter plan. This year, there was a slightly different approach taken by Scottish Government, whereby they gave us 8 different priorities and a checklist that we had to complete in terms of how prepared we are for winter. There is no formal requirement this year to submit a plan to Scottish Government, albeit I know that for NHS Tayside Board members, the full plan is coming to NHS Tayside Board tomorrow. So we have undertaken that piece of work both locally, and we've linked in regionally with that and looked at the gaps that we have within Angus and what will inform or what does inform our winter plan going into the next few months. The main focus around the winter plan for Angus is how we achieve timely care in the most suitable setting and supporting individuals when they are admitted to hospital. How do we support their transition back home to or a homely setting as soon as possible? So there is a lot of work that has happened. There's a lot of work that is ongoing. Angus is a partnership who performs very well in relation to delayed discharges. So that's something that we are aiming to continue, and one of the recommendations in the report is to approve our proposed target for our delayed discharges going into the winter, and the commitment from the partnership to work within green status as far as possible. I think we recognise that will fluctuate on a day-to-day basis. I think it will be very, very challenging to stay in green every single day of the week, but just to give a level of evidence that if we do move from green to amber, that we do have a process and a system in place to support what actions we need to take to get that back down to green. In relation to the financial element of urgent and unscheduled care, traditionally, we would, again, on an annual basis, have a winter allocation. That isn't something that's come forward this year. And the funding that has come through for urgent and unscheduled care has been redirected to support the Flow Navigation Centre within ED in Ninewells Hospital. And Sandy might want to come in around urgent and unscheduled care funding if he has anything that he wants to add to that. We did in his paper and cross-reference ours that there may be cost implications and cost pressures over the winter period. Again, it's very difficult at this moment in time to define exactly what they are going to be and how much they're going to be, but that is something that is very much on our radar. I think the report for us underscores the importance of addressing some of the challenges that we've spoke around urgent and unscheduled activity across the region and indeed across Angus. The other part of that is some of the challenges and the increasing demand that we are experiencing in the GP out of hours service as well. That is increasing, and we are going to be to embark on an ecosystem for out of hours to inform some of that kind of quality improvement approach to inform what out of hours could look like in for 5 to 10 years in terms of that sustainability around that. So I don't know if Scott, as kind of the clinical lead for urgent and unscheduled care for Angus, wants to come in and add anything.
I was going to ask if Scott wanted to do that, so the floor is yours, Scott.
Well, thanks very much, Chair. Jill, thanks so much for a comprehensive summary of our report there for the IGB. I'm really proud of how we've approached it. I'm really pleased with the support that particularly you've given in yourself and with leadership position within that as well, and the support of Gail as our Chief Officer to certainly have confidence at that strategic level to say, look, you guys know the QI, you know the data. I trust my clinicians, and a clinical-led model to improve urgent care is by far the best way to do this. Over a model where we have to propose, guess what an improvement might look like, and I have to kind of ask Gail to pick the best one that she thinks is the right one, and that's just not the right way to do it. And we've certainly not looked to do that in Angus. I'm grateful to the support as well that we have had from Lindsay Day, the Programme Manager for Urgent Care. That's been a really key investment for us to make sure we've got that bespoke programme management support into urgent care, and a huge array of work across pharmacy, across our minor injury units, and certainly out of hours, as Jill alludes to, is going to get a focus from us to make sure that we give that right QI support around it, to wrap around and make sure that we make improvements in the service that we deliver, and make sure that we're a responsive urgent care system which is providing care as close to home as possible within the resources that we have available. And as much as the winter always sets us with a bit of trepidation, I'm also looking forward to seeing how we respond and how our systems flex to that need. We've had great investment in the urgent care setting as well with regards to advanced nurse practitioners who are now in place to support all practices across Angus. We've almost got full recruitment there, which we're a long way from where we were before, but lots of trainees within there as well is the other thing to highlight. A lot of training requirements to make sure we get the advanced nurse practitioners up to that fully qualified level, but we've got support around that as well. So it's great to be doing it like this, I have to say, and it's great to have the support of the IGB and of Strategic Plan Group and others to develop services like this, but also to give that reassurance to the IGB about the service that we're providing. Happy to answer any questions from the board, Chair. Thank you.
Thank you very much. Any questions from anyone on this paper? Having visited the Flow Navigation Centre last year and seen how it works, it was pretty smooth, and yet we have to counter that with unexpected things that come up, like last weekend, and additional pressures on the system on a scale that it's hard to predict. So with all those caveats around the finances and contingencies, I think we're probably good to go on this paper. And I would just like to acknowledge all the work that the team has put in on that. I know Jill and Scott were the faces on screen here, but there's Lisa and Lindsay at the back that we're really grateful for all your work on helping to develop this. So on that note, if we can just go to the recommendations and ask the IGB to accept them on block. Oh, sorry, Andrew, didn't see that.
My apologies, I was clearly too subtle with my hand. Just a couple of comments, if I may, rather than necessary questions. I do have a slight concern in terms of the complete diversion of funding into the Flow Navigation Centre, especially as the distance to travel from where we were in Tayside before Flow Navigation was invented to where we are now is probably less of a leap than in other board areas. And to then remove funding for other areas to support winter planning seems not the most positive step in my personal opinion. I think the other comment I would make is it highlights here an anticipation of 15% increase in activity in the GP out of hours service. That's not isolated to the GP out-of-hours service. The trouble is we don't have a way of measuring unmet need and demand within the in-hours service because there's no way of recording it, whereas, of course, you can easily record every patient that calls NHS 24 or makes a direct contact with the FlowNav centre, but we don't record that and can't record that in standard in-hours general practice. So it's some recognition in there that pressure is throughout the system and not just in that one isolated area, and I think that is important. And I think that was it. Thank you very much.
Thanks, Andrew. Come in there. If you put your mic off, please. Thank you.
Thank you, Andrew. Just a couple of things. So I guess just in terms of clarity that it's not the winter funding that's been redirected to support the Flow Navigation Centre, it's urgent and unscheduled care funding. So there's two different funding streams associated with that. So just for clarity, because it isn't winter funding, I think in terms of the 15%, sorry, just to go back on that, we did get recurring funding, 21-22 to support winter, so that is in place. In relation to the increase in demand across the system, really challenging to manage across the whole system. I think on a personal level, but on a wider level, do not underestimate the importance of good, urgent and unscheduled care to support the whole system. And that's not just from a healthcare perspective, that's from an integrated perspective, because the social care element of urgent and unscheduled care also plays an absolutely pivotal role in supporting that whole system. I think we're actually very lucky in Tayside in relation to how our acute colleagues support the urgent and unscheduled care services, and they recognise the importance of primary and community services in that whole system. So they are very keen to work with us to look at an escalation around. It's not just if there's 20 delayed discharges in the hospital that things tip over. Actually, if we've got those pressures within the community setting, there's more of we're kind of pushing it a bit more of an open door now for us, that to be a kind of a two-way conversation around that escalation and what that system can then do to support us, not just what we can do to support the secondary care and acute side of things. So a really welcome environment to be working around urgent and unscheduled care at the moment.
Thank you. Are you okay with that, Andrew? That help? You want to come back in?
Sorry about this, Jill. Yeah, I completely agree with you and welcome that response. I think one of the things just to note is one of the biggest providers of urgent and unscheduled care is in-house general practice as well as social work, as well as, and again, that's not specifically recorded. But a lot of practices have had to maintain systems that actually rely on urgent and unscheduled care and triage of care requests on a daily basis, far more than ever before the pandemic.
Okay. So on that note, if we can go back and are you happy to approve the recommendations 1 to 6 as listed? Thank you very much, everyone, and thank you, team, for your work there. And I'm going to ask the IGB to allow me to bring item 13 up to the agenda next. It's the Chief Social Work Officer report. It's a timing issue. So, Catherine, if the floor is yours. Thank you. And I have noted for future reference, we would like to see your annual report higher up the agenda for a lengthier interrogation and absorption of it. Thank you.
Well, no pressure, Chair. Thank you very much for agreeing to pull the report forward, and colleagues for agreeing to allow that to happen. I appreciate the opportunity to introduce this year's Chief Social Work Officer Annual Report, which, as you know, covers all aspects of social work and social care services delivered by and on behalf of Angus Council, and that includes those delivered in the Health and Social Care Partnership and overseen through this Integration Joint Board. Reflecting the complex governance arrangements for social work and social care, this report has also been considered by the Local Authorities Scrutiny and Audit Committee, and it was approved at full council in September. The report is calling today for members' information, but also for discussion on matters that are relevant to the functions and the influence of the Integration Joint Board services. So some trends during the last reporting year that members might want to note include, and you've heard all of this information before in various reports, so apologies for the duplication, but the positive outcome of the multi-agency joint adult protection inspection, reflecting a culture of strong and compassionate social work practice. I'm obviously speaking only about the social work elements of that and social care elements of that today, but it was really a joint effort across the whole partnership. A continued and significant increase in adult protection referrals, together with an increase in the number of families requiring children's social work intervention. And that mostly reflects the support needs of key adults in their lives, as we spoke about when Dr. Fletcher presented her report earlier. A range of pressures that are impacting the availability of resources to look after our children who need to be looked after away from home is a significant pressure within Angus, but it also has knock-on consequences for our adult and young people's population. There's also a high performance, and we've just heard reference to that also in relation to delayed discharge measures across the Angus area. A continued and significant reported level of unmet need, though, underpins that, and I know that there's going to be some further update on that in relation to another report. And then finally, the continued demand for mental health officer services across the lifespan. And again, just to reiterate that the partnership offer in relation to mental health officer services includes children and young people as well. So whilst we often in this meeting focus around discussing adults and adults' needs, there are key components of what the IGB are responsible for that actually stretch across the lifespan. So together with colleagues from the partnership, we'll be happy to take any questions from the board today around any of those themes. And once again, I want to take this opportunity to commend our workforce, our paid and our unpaid carers, our partner agencies for their commitment and their dedication to supporting those across Angus who really need it. Thanks very much.
Thank you, Catherine. And as one of the people who have seen it at committee or council twice already, I'm not going to burden you with any new questions, but I do open the floor up for questions from any other member around the room. Lois.
Thank you, Chair. Yeah, I've also had the opportunity, but I don't mind burdening Catherine just with another question, especially given that we're in this forum here and the overlapping themes that you've mentioned, Catherine, but in particular that transition from children to adult services for many who require it, and it's been quite nationally known that it can often feel, it's been quoted as feeling like a cliff edge going from one to the other, and there have been kind of gaps in that provision of support. I just wondered if you could briefly and quickly update us on the transition work that was carried out and what differences that is making.
Thank you very much for your question, Councillor Speed. And you're quite right, there has been a programme of work ongoing exploring transition. Transition, of course, encompasses a wide range of different needs and different groups across Angus, and it is very much around that transition from being a young person to considered an adult and in receipt of adult services through the partnership. Now, I know that Eunice McLennan is also with you in the room, and Eunice had played a substantial role in chairing our transitions group, and I wonder whether Eunice might want to come in and provide a little further detail on where that activity is at.
Thanks, Catherine. Eunice is all ready to come in there. Thanks.
Thank you, Catherine. Yes, more than happy to discuss the work of the transitions, which has been a really sort of fast-flowing group. We've done a lot of work in the last 18 months to try and really focus in on where we don't have pathways of care for young people. So we have had scoping exercise. We know we've got a lot of really good pathways of care. So if you're looked after, your care experience These pathways are all, working reasonably well. We had challenges around pathways for young people accessing adult support and protection that have now been resolved. We've been working with our colleagues in children and families to make sure when young people are transitioning into disability services, for example, that we are working together, we are supporting families, so there's not a sort of obvious change in direction, expectations, SDS packages, etc., so that we're trying to be realistic about what we can provide, but we're supporting that journey. At the moment, we're doing some work around young people that don't really fit into any of the services that we have within the partnership, and how can we make sure that we accommodate those that actually have a level of need that require more sort of additional support. And we've got an exercise coming up next month to try and look at that in more detail, learn lessons that will be fed into our service review that Mr Cooper's already mentioned. So lots of work going on around transitions, and really excited on vulnerable young people and how we can make a difference to them. Thank you.
Thank you very much, Eunice. Any more? Councillor Meehan?
Thank you, Chair. My first one's a comment, if that's okay. It's regarding the information provided, which I think when we look at some of the reports we've had today, it links very well. The report tells us that the annual increase in welfare rights referrals was an additional 1,500, taking it to 5,400 households across Angus. We've actually sought advice on things like fuel poverty or additional benefits and so on. So that's interesting, but I think it flows with the other reports that we've heard today. The second one was on the increase in referrals to family support services. Last year, 622 referrals progressed, which has increased to 806. Now, I think it says here it's a 30% increase year on year. And I suppose the question I would have is, how has this impacted on staff and their ability to actually manage this large increase?
Thanks, George. I'll ask Catherine to pick that final point up.
Many thanks for both your comment and your question. And whilst Children's Social Work is out with the direct purview of the Integration Joint Board, I'm sure that members are very interested in the impact that this increase has had. And you're right, it is a substantial increase. So you'll see that the report talks about the number of referrals that we receive, and the number of referrals, have been fluctuating over the years, and that's always something that we give some consideration to in the report. This year, we particularly looked at the conversion rate from an original referral to actual social work ongoing support being required, so a fuller social work assessment rather than perhaps advice and guidance and signposting to other universal services and other targeted services, perhaps to support the family and members in that family, and that might include health and social care partnership delivered services for adults. And what we've seen in that last reporting year is a substantial increase in the number of assessments that are being required of children's social workers. So of course what that does do is it increases the caseload of those individual social workers and their teams. So that has come with a significant cost to staff in terms of their busyness, the length of time they're able to spend with each individual child that they are responsible for supporting, and a degree of frustration around not being able to spend as much time with individual families as they might like to do. We have been making very good use of our wider support services, so whilst we might be undertaking the assessment, we don't always necessarily then continue to deliver the package of care and support entirely on our own. We're part of the wider GIRFEC, Getting It Right for Every Child approach. We draw very heavily on both adult services support and children's services support that are not direct social work services in order to supplement and enhance those packages of care and support for children, young people and their families. But you're absolutely right to point out that there's a significant capacity issue emerging in relation to that side of our business, and we'll watch with great interest how that progresses over the next year, particularly given Dr Fletcher's report and a Professor Bywater's report, which highlighted quite particularly the linkage between poverty and increase in poverty, and then increase in child protection and the number of looked after children in an area. Thank you.
Thank you. And we are, of course, the lead partner for primary care, which does provide a service to children right the way through. So that element of it is particularly, but you're right, there is a wider interest because children need to be an absolute priority in all that we do, and it's certainly a view we've taken in terms of tackling poverty. So thank you. Does anyone... Oh, David, thank you.
Thank you, Chair. Just very briefly to acknowledge the reference in the report to the support to carers, both adult and young carers. That's appreciated, but also I think there's an acknowledgement that the increasing volume of identified need for support, as Catherine says, that will continue to provide a challenge in terms of resourcing on an ongoing basis. But I think it's a very positive statement in there about that. Thank you.
Thank you. And I think there's more work being done to reach young carers particularly, so that is likely to increase, but it's an utterly vital piece of work that needs to be done. So, George.
Sorry, Chair, I missed one out. Again, it's just a comment. It was very good to see that Angus are a fair bit above the national average for successful completion of the community payback work. So that was really good to see. Thank you.
Brilliant. Thanks very much. Very positive comment. So unless there are any more questions, I'm very happy to proceed to accept the recommendation, which is around noting the contents of the Chief Social Work Officer's report. And I think that's another document that we do need to bear in mind in terms of delivering on strategy. So thank you very much, Catherine. And if you wouldn't mind passing back our gratitude for the work that your teams do in delivering care to people in our communities across Angus, I'd be very grateful. Thank you.
Thank you very much.
Cheers. And now, if we're moving back to, I'll give you time to catch up on your pages, page 238, which is our workforce planning progress update, and it's Eunice at the mic. Thanks.
No, it's not a good start. Thank you, Chair. I'm sure everybody will agree that workforce is key to everything we do, and I'm delighted to bring this report to the IGB today to share the successes and some of our challenges around workforce planning. This report provides an overview of our workforce planning over the past 12 months. The purpose of this annual report is to allow us to evaluate progress and ensure our workforce priorities and challenges remain the same or require to change accordingly to meet our needs and demands. This report is very much a team effort, working right across the Health and Social Care Partnership, and you will see from the papers that we have 5 work streams addressing all aspects of the workforce. We have lots of energy and drive in this work, and you will see from the report a number of successes that I would wish to highlight just now. You'll note that in terms of staff vacancies, although we have challenges around this, we have increased the number of permanent contracts within the partnership, and we have also retained a number of staff. Sickness absence is something that we're working hard to address because that can impact on service delivery, and we have been working with our parent bodies and the policies that are in place, and we have seen significant decrease in sickness absence, particularly around some aspects of our staffing in Angus Council employed staff. We have done a lot of work around recruitment. We've already heard today around the unmet need, and we're working very closely with our care providers around recruitment of staff. And we have, at the time of writing this report, seen an increase of 54 people coming in to jobs in the care sector. We're also working with schools, colleges and universities and working on foundation apprentice placements, and we have doubled the number of apprentices coming into the partnership in the last year. We've also been working to increase the number of trainee district nurses, and we have established a number of applications for these roles. Initial review that we had 5 trainee nurses in post. Unfortunately, that hasn't exactly materialised, but we're still being positive around this, and that we are developing much more interest in the district nursing workforce. Care at home providers have noticed an increase in suitable applicants that are coming forward to work in this sector, and we're really working closely with colleagues to make sure that we can address the vacancies there. In the last year, we have seen an excess of 50 new posts established within the workforce, which is really a good piece of news. However, within that, we're also seeing a number of workforce challenges, which I would want to highlight as well. We've already heard about demographic changes, including an ageing population and an increase in complexity of need. We've seen a demand for an increase in end-of-life care, an increase in quantity of care and support required by individuals as people stay at home in their own places for longer. We've already heard in the Chief Social Work Officer report about the adult support and protection work, and we've seen an increase in referrals in this area, along with an increase in Adults with Incapacity Act work and the number of guardianships that are required. We do have difficulties recruiting staff in general and difficulties recruiting to specific posts, but we've identified where they are, and we have a register of hard-to-fill posts that we review on a bi-monthly basis to make sure that we're on top of these areas. We have done a lot of work around trying to ensure that we are training our workforce, making Angus a good place to come and work for the partnership. And over the next 3 years, we're going to continue to address innovative ways of working to ensure that we can meet the needs of the people we're here to serve. Today, I'm going to ask the IGB to ensure that we agree the content of this report, acknowledge the progress that has been made in the first year of the workforce plan, and approves the annual update of the workforce plan. I'd also like to say that I've got Fiona Davison here as well, who's been a lead on the workforce, and both of us are happy to take any questions. Thank you.
Thank you very much. And just briefly before I open it up, in terms of safer staffing levels, I know that's a challenge that's coming down the line quite quickly, but also modern slavery legislation, that's a concern as well, and it would be good to see referenced in our planning.
Okay. We can certainly take that on. In terms of safer staffing, we have a subgroup particularly looking at safer staffing across all the different professions within the workforce that safer staffing will be impacted by. There's a new legislation that's coming in April 2024. Unfortunately, there's no additional funding being provided by the Scottish Government for this. So this is a challenge, and it is a risk for us as we try and manage the demands, want to meet legislative requirements, but we don't have any additional funding. So that's where we're at with that. In terms of modern slavery, we certainly can reference that within the report. We've also done some training through the public protection agendas, highlighting that to staff, along with other agendas around trafficking, etc., that people should be mindful of and aware of. Thank you.
I was pretty sure that work was being done. It's just not been referenced. So thank you. Do you have anything you want to add?
In relation to the safer staffing, it is referenced within our action plan, which is a lot more detailed in terms of what we're delivering locally. Interestingly, there was a national workforce planning conference for Scotland held yesterday, and modern slavery was brought up at that. So it is, something that I think the figure given was 18% of the UK's social care and health workforce is currently subject to modern slavery. So it is something that, again, there is going to be a national focus on.
Thank you. That is a horrific figure, absolutely horrific. Donald.
Thanks very much, Chair. And thank you. This is, as someone who doesn't normally attend this IGB, it was interesting to read this report. I thought it gives a really good snapshot of what's happening across the Health and Social Care Partnership in Angus. The thing that I noticed, I mean, there's a section around culture and leadership within the report. It's page 261 of the pack, or page 18 of the report, and it talks a bit about leadership and leadership development, and I welcome all of that. But it didn't have much to say around culture. What does it feel like to work within the Health and Social Care Partnership? And I know clearly we've got a situation where we have two partners, each of which have their own ways. So, for example, in NHS, it's iMatter. I'm sure Council will have a similar measure. But it would be useful to have read something in the report about, as I say, what does it feel like to work within Angus Health and Social Care Partnership, and how do we take the temperature, and how do we change that from time to time?
Thanks, Donald. Eunice is going to come in there.
Thank you for your comments, and we'll certainly make sure that we add something further about culture. So I think we've done quite a lot of work on culture in the last year or so. All staff in the partnership are included in iMatter, and our iMatter return has been submitted, and we've got our action plan that we're working on. We have set up a SMILE event, which is a senior management integrated leadership event, and that is to look at cultures of kindness, working together, how we can break down barriers of working. We've also introduced a middle manager event. We had a Celebrating Success event in May. We've got another one coming up in November. So we are trying to work together and look at our commonality rather than our differences. And I think that's been really quite successful. We'll certainly be able to highlight that further in future years. So thank you for that comment.
Thank you very much, Eunice. Anyone? All right, is Chris first, or Chris first and then Alison?
That's good. We'll leave the mic on because we're sharing it. Okay, thanks for the report, Eunice. Just a few points from the content of the report. They're in order of the page numbers rather than importance. You mentioned on page 255, the first bullet point talks about an increase in the numbers of people contacting the partnership to find out about a job in care. I was wondering what the data was behind that, of the success of those people who were contacting the partnership ultimately ending up in employment. Because I mean, your query is, as I'm sure everyone would appreciate, is one thing. Seeing somebody into a hard-to-fill post, or indeed a vacant post, would be a different offer. The third bullet point talks about increasing social care officers' contracted hours. We spoke about that earlier in the meeting today, and about the concerns that I would have on behalf of staff about that being a finite, short-term proposition, because you can only increase a dwindling workforce, an ageing workforce's contracted hours to a maximum before that's not something that you can do anymore. So whilst it's recognised that that's how one of the things is increasing contracted hours to address capacity, it would be to point out that it really is it's a short-term fix and not a long-term fix in our view. On page 256, you'd spoken about, or the report referenced, whilst care providers have reported an improvement in staff recruitment activity, retention of staff remains a challenge. Recruitment and retention of staff is something that we've brought to this board, and I brought to this board as staff rep for Angus Council employees. I think probably just about every IJB that we've been at, and flagging up the issues around recruitment, around retention, particularly in social care, about how we recruit and retain staff against the terms and conditions that they work for. Now, we had some input earlier this year into a procurement exercise where we came up with a number of ideas about enhancing the offer for people in social care, such as occupational sick pay, for example, just as one suggestion. So I was wondering what the partnership were looking at. You spoke about looking at more innovative ways of working in the future. What's the partnership doing to mitigate and manage those consistent and persistent recruitment and retention challenges in the partnership? And the last point I'd like to make, sorry, it's 4 altogether, I think, better doing them all at once. I was on page 269, and you referred to sickness absence and staff absences. And obviously it would remain a concern that nearly 1/3 of staff absences across the partnership have been attributed to psychological reasons. That will be mental health, workplace stress, anxiety, etc. Against the issues that we've raised about fewer staff, particularly longer hours, what proposals and plans would the partnership have about increasing the access to support facilities such as PAM Assist and other ways in which staff with psychological reasons for being off work can be supported to address those issues and indeed bring them back to work. Just as one small example, I know that PAM Assist exists and works well, but often that's for 6 appointments. Okay, people with longer term mental health issues need more than 6 appointments, and that's at the behest of the council, certainly can I speak for the council rather than the NHS, to apply for more sessions. That's not always agreed and would be needed. So it's what you would have in place to address those reasons for people being off. Thank you.
Thanks, Chris.
Thank you very much. So, well, do a double act with Fiona in terms of responding to this, because she is lead of the recruitment and retention workforce group. But what I would say is, just before I invite Fiona to come in, we have a staff health and wellbeing action plan that was developed on the back of a survey that we did to staff last year, and we got 331 responses. And stress was quite a big driver, that people said stress, workload. So we have looked at that, and we've got an action plan with a variety of approaches that we're doing across the workforce. So we've been doing things like, addressing how we do emails, because people can find the pressure of having, volumes of emails. In supervision, staff health and wellbeing is on everybody's agenda. So how are you coping? How are you managing with your workload? What do we need to do differently in order to try and help make you feel that you're comfortable with the work that you're being asked to do? We have had sort of further events to try and look at that. We had a yoga session, for example, as a one-off to try and look at how we can try and just help people relax in the workforce and take time for themselves. We've put out a poster encouraging people to have good workforce practices. Take your lunch away from your desk, drink plenty of water, work hard but leave on time, look after yourself. So we're really trying to give the messages that your health and wellbeing is really important to us as a partnership. So in terms of some of the recruitment things, I'll come to Fiona around that, and then I can pick up any other comments.
Thanks, Judith. Can I maybe just add a little bit? So, Chris, develop direct access to psychological therapy services through NHS Tayside services for staff during COVID, which has continued. And as part of that, we did look at our own PAM Assist services within the council, and that contract was actually reviewed in light of that to make sure that staff also got further assistance when they needed it. There's also the Able Future service now, which is available to staff, and we've developed a staff health and wellbeing toolkit and resource pack on the internet for across the Health and Social Care Partnership. So that also gives staff access to a whole lot of tools at different levels, and access to some of the national ones that are available now as well. And there's direct counselling. There's a national hub that has direct counselling available to staff that work anywhere in health and social care too. So we've been promoting all of those things, as well as looking at doing all the things locally that Eunice has mentioned, because we've got a health and wellbeing group for the workforce. This is unprecedented workforce challenges nationally that we've been experiencing. So the health and wellbeing of our staff has been a huge priority for us, and will continue to be. So we continue to put as much focus on that as we possibly can. So that was just to finish off in relation to the health and wellbeing. And in relation to some of the recruitment issues and the recruitment challenges, they're very difficult challenges. There is not a magic wand. At that conference yesterday in Scotland, everybody is obviously struggling with these same issues. What I can say in relation to ourselves is that we have been, we have a recruitment and retention group. We have been targeting all areas of the population in relation to looking at recruitment and retention resolutions. So we have been targeting young people, we've been targeting people that have been unemployed, people that want to return to work. We've been working with the colleges, we've been targeting the refugees and new populations that have been coming into Angus. And we've also been looking at, most importantly as well, ways to retain our own staff and continue to support the development and the retention of our own staff. Yesterday at the National Conference was also the day that they announced the living wage rise to £12 per hour. That was a disappointment across the third sector and the voluntary, or the independent and the third sector, and that is something that nationally there will be challenges going forward, because until we can actually get above the fair work, the fair price for fair work, and get a social care workforce seen to be of more value than the national minimum wage, then this is going to continue to be a real challenge right across the country. But we have a recruitment and retention group. There's a lot of energy around it. We've got a multi-agency input into that, and we continue to have a focus and very creative and innovative solutions locally around how we're going to continue to address the challenges in Angus for that.
Thank you.
Fiona, thank you for the responses. Yeah, I'm aware of the recruitment retention challenges. I know there's no magic solution, but magic solutions could in the future be focused around what the offer is, what the gift is, and and we hear all the time about younger people being approached. But if other jobs are more attractive, then what do we need to do to make our offer in social care more attractive and a better proposition than job A, B or C that may be an alternative for somebody to go for? But thank you for the information. It's something that we care passionately about, because we want the partnership to deliver the best social care that is possible. But if we can't get the people, then we need to look at what the offer is and make that more attractive. And that's how we tried to feed into the previous procurement process, to actually give some ideas about how that work could be made more attractive for people to come into. Thank you.
And I think, to be fair, sorry, if you pop that off, thank you. I think, to be fair, that was something that came out in the Feely report and the ambitions around the National Care Service about improving not just terms and conditions, but the career pathway in frontline social care, and allow them opportunities that bring out the best in people and keep them in really important jobs. So we will see how that evolves. Eunice.
So just on that, we've actually got a succession planning work group as well that we've just set up on a temporary basis, just to try and look at that, so that we can invest in the workforce and we bring you in at whatever grade you come in. But we want to keep you, we want to develop you, we want to grow you. So we have a succession planning group that's looking at all these kind of aspects as well. So once you're in, we want to hold on to you. Thank you.
Thank you. And Gail's asked to come back to Donald on one of his points before I bring Alison in.
Donald, just reminding me, last week at the National Chief Officers Group, they were asking the Chief Officer about how they felt culture was reporting to two organisations as well. So there's also a national piece of work being led through Angie Wood and her team, Donald, looking at culture as well.
Thanks, Gail. Alison.
Thank you, Chair. It was really coming back around the comment around culture and leadership as well. We've had, and I really have to acknowledge, this is a huge piece of work in quite a short piece of time with this workforce plan. It's extensive, covering lots of areas, and we'll continue to have new areas, and I would support that health and well-being being a huge emphasis within the workforce plan, because I'm always getting into trouble for sending lots of emails when I shouldn't be. But building on that, we have discussed in the Clinical Care and Professional Governance group around professional leadership, and that was in the background of the Letby and Elgimel case, so locally and nationally concerned around professional leadership. And for me, that's a huge part of how we create the right culture and the right leadership about recognising that professional leadership. So Eunice has agreed to take that through the workforce planning group around how we, and that's across the clinical professions but and also social work professions. And I think if we can get that professional leadership structure right, that will help both with the succession planning, recruitment and retention, and culture and support for staff. So it's just to make you aware of the importance of that, I feel, and that we're taking that forward. Thank you.
Thank you very much. And as Donald is the current whistleblowing champion for NHS Tayside, he will know the importance of having a culture that things don't get to the whistleblowing stage, heading them off at the pass, really, and having a culture where people can talk about any concerns well in advance of it escalating. So thanks for pulling that in, Donald. So unless there are any, oh sorry, Nikki.
Thank you. It was just to say in regards to the recruitment and retention, I mean obviously everybody's fishing in the same pond, and what I'm hearing is providers are just moving, well, care staff are moving from one provider to the next, and that's going between care at home and care homes. And it's just basically because they think they're going to get that really small bit of additional money, or uniforms paid for, or something like that. And the other challenges that providers are facing as well is people are moving, only maybe staying 1 or 2 days sometimes, and the time and effort that there is into recruitment, costs into uniforms, training, etc. So it's just an additional pressure. And again, what Fiona was saying, I completely agree about the £12. I think, well, it's great for those other workers as minimum wage. I think for skilled and qualified staff working in the care sector, for that to be comparable, I think's a concern. And sorry, just going back to the moving around, I think if the pay and conditions were the same for everyone, regardless of the care, provider you were working for, I think that would stop that moving around. But thank you.
Thanks very much, Nikki. And unless there are any more questions, can we move to the recommendations on page 238 as listed on the paper, and to thank you, Eunice, and Fiona and the whole team for the level of work and attention to detail in the subgroups. I fully appreciate there's lots of information that underpins the paper that we've got. Is everyone happy with those recommendations? Thank you very much. That's lovely. So if we can now move to number 11, which is the annual performance report. And before we go to that in detail, you will see that there are two options that we're being asked to choose from. I'm going to be a bit directive, which is not my default setting. I've been swinging about from option to option on this, and I am coming down on the option 1 at the moment, because I'm really aware of the burden of extra work it is for officers to organise an additional meeting. And what I have done already around this discussion is to ask for it to be placed on the agenda of the IGB Chairs and Vice Chairs Network meeting. And it's already on the agenda of strategic groups that chief officers and others are involved in, so that we could potentially consolidate the timing at a national level, so that we're reporting our performance reporting in August when it's a logical time, rather than do it in a kind of mashed up kind of way. I am very reluctant to ask either officers or IGB members to put an extra meeting in their diary. That's why, but I'm also aware that officers are uncomfortable about placing incomplete performance data before us earlier on, which is why it has come to the IGB. But we are trying to address it, and I think if we haven't fixed it by next year, we'll have to deal with that. But I would like to see movement on that nationally, so that the whole system benefits from it. It seems a complete anomaly to me that we are scrabbling around to finalise the data. So with that in mind, so hold that option 1 preference that I'm asking you to consider. Can we then move to the actual report? And Gail's going to come in.
I'm going to bring Jill Galloway down for the report. But as Julie said, with regard to that recommendation, and particularly in light of the discussions we were having earlier about the delegated authority to the Chief Officer, you know, I can submit that report without obtaining IGB approval, which is what happens, but I don't feel comfortable with that, as many of you understand. I would rather you see it first and you approve that report prior to that report being submitted. So likewise, I'm listening to Julie, and I've got complete confidence that the Chair and Vice Chair's group will be able to move that piece of work, or there will be a dilemma later on next year. But that's my personal view. Thank you. Jill, can we bring you forward for the actual report?
Thank you, Chair, and thank you, Gail. Yeah, I'm not going to go through the report in full detail. The key points were brought to the IGB in June in relation to our kind of dashboard, or August, I can't remember which one it was now, I think it was August, in relation to the key points of the data. So what we are looking for today is IGB's endorsement of the annual report to allow us to get it published on the website.
Thank you, Jill. Anyone have any questions on the annual performance report? Not seeing any hands online either at the moment. Everyone okay with that? Okay, that's excellent. Thank you. And do you agree to option 1, which is a vital piece of the decision-making process? I really appreciate that, because I genuinely was going to leave this open to a complete debate, but I have reflected on it, and I do think option 1 is the best option. George?
Yeah, I've heard what you said, obviously, but it maybe sticks with me a little bit that the Chief Officer puts it forward for publication and approves it, and the board doesn't. Is that not why the board is here?
In practice, though, it comes to us in draft form, and it still comes to the IGB again later on with the completed data. The challenge is that the process doesn't allow us to have the confirmed data in place by the time it's required for submission. So what I'm trying to get, this is sounding terribly ambitious as I articulate this, given that you guys haven't managed it already, but what I would like to happen is that the national statutory requirements for submission of this allow us to consolidate the publication of this at the right time. So we don't have to do it twice, and we don't have to do an extra meeting. So I'm just asking for, I guess, a status quo. We have always brought it. Yeah. So legally, there's no need for that, but we have always brought it. So the way we've been doing it is what you would like to see, but that's already happening in practice. So all I'm asking is that we go for option 1. We don't have an extra board meeting in July, so everyone gets a bit of a break from formal meetings and there isn't a scrabble around to complete it. I would like to see if we can nationally get an agreement around moving the publication date to a time where the data is available and it can all be published in its finished form without having that raw step in the middle that is hindering everybody. It's a national problem, George. Is that okay?
I don't have an issue with that. It's just that I attend more and more meetings and committees and so on, and it appears to me and it's nothing to do with this, but I'll say it anyway, is that we appear to delegate more and more and more and more to chief officers and others, and you start to think to yourself, well, you know, why am I here? But no, I'm happy with that. I'm happy.
So legally, it is designated, but we don't do it that way. It does come here, and it's to avoid the extra faffing around, also a technical term, for officers, so that we get a proper document in the public domain at the right time. Yeah.
Yeah, I think it is one of the discussions at the National Strategic Planning Officers Group as well. I think we'll have to acknowledge the impact that it has on our ability to submit our annual accounts as well, and that does play a part in terms of when we can come to the IGB with signed data that is fully quality assured, but also supports the submission of the annual accounts as well. And Chair, just if I may just pass thanks on to Paul Feltham, who's put a tremendous amount of work in pulling the data together. Thank you.
Sure, thank you very much. And there is a lot of work going on nationally around consolidated and accredited data and dashboards that are popping up all over the place to allow us to monitor in real time unscheduled care activity. So it's really great to see that, but it is on the go. So it's a logical point in the process to be able to raise it again nationally to complete that picture, if you like. Yes, very much endorse feedback, and thanks to Paul as well. So thank you very much for that. So recommendations, there are two: approving the content of the public performance report and approving one, which is a status quo, to allow us to progress, and the other issues will be progressed nationally. Everyone happy with that? Thank you so much. That's a weight off my mind. And the next item is the Angus Alcohol and Drug Partnership update. And Jill's kicking that off, so thank you very much.
Thank you, Chair. I'm conscious of everybody's time, and I'm assuming that people will have read the report. I'm also acknowledging the fact that we do have a development session coming up around alcohol and drugs as well for both strategic planning and IGB members. This is our very first Angus ADP annual report, and I'm really pleased that we've got to a position to be able to pull the report together to start to describe some of the work that we have been endeavouring to undertake over the last year. Acknowledge that some of it may sound as though it's out of date and things have happened, but because of the delay in actually bringing the report to the IGB, that's the reason for referring to some things coming to IGB in June, etc., which I know has happened, but it is an annual report for 22-23, and I think just reflecting back to some of the conversation around the public health report, the discussions that we've been having around proactive care and prevention, I think it just again highlights the importance of having a really good, strong alcohol and drugs partnership. And I think that within Angus, we do have a strong ADP. We have an engaged ADP, and it does allow us to progress and have some really difficult discussions around topics that are quite upsetting as well for a number of people. It allows us to support that whole family approach. I know we've spoke about that before, so that we are, although children aren't part of the IGB, we absolutely understand that where parents have substance use challenges or issues around their mental health, how do we support that whole family? It's not just around supporting the individuals themselves. So in the report, you will also see some qualitative feedback, because we, again, have a really good way of engaging with our service users within the service, and it does reflect some of the good work that's going on with the wellbeing cafes, etc. So the importance of that qualitative aspect of the service as well.
Thank you very much. And Lois and I both sit on the Alcohol and Drug Partnership, and there's huge overlap, obviously, with other partnerships, such as the Community Justice Partnership and Violence Against Women and Girls Partnership. And in fact, Lois and I have been invited to go along and meet with some family support groups through the ADP and I'm going to one tomorrow night at the fire station in Forfar. So, you know, really good engagement work. Is such an important and well-functioning partnership, actually. So we've got a lot to be proud of there. So have got any questions from anyone to Gillian about the annual report? No questions. Oh, sorry, Catherine. And then Lois.
Thank you. It's less of a question and just more of an observation. I was really pleased to see reference to the focus in relation to cocaine use in Angus as an issue that's coming up through protecting people arrangements as a growing concern, lying behind some other challenging behaviours that communities are experiencing. So it's helpful to see the work that the ADP are looking to support in relation to that. Thank you.
Thank you. And Lois.
Thanks, Chair. And yeah, mine was more just really a comment and just an acknowledgement and endorsement of the report. It's pleased to see it being brought, and I think it's definitely very clear, and I think it's hopefully the good kind of basis or template for moving forward. But yeah, thanks, Gillian.
And please pass back my thanks. I know how challenging it can be to get all the data in because I get copied into the emails. So just let me find it. Oh, sorry, George.
Sorry about this, but
That's okay.
I missed what Catherine said. The part, so the emphasis she had, I missed it when
I think it was about cocaine use.
All right,
wasn't
okay.
It? Yeah,
Right,
it was
thank you.
cocaine use. Yeah. There are some interesting developments in some use. Do you want to come in and talk about that?
I can give a very brief overview in terms of what we are seeing is quite a significant shift of opiate use to cocaine use within certainly across the Tayside area, but we do have, for those that are coming to the development session, a really interesting presentation around that and around the demographics, male, female split, the age group. It's actually quite an interesting but quite a worrying picture, and it absolutely fits with the public health report. So look forward to some of the discussion at the development session. And I think, again, just to pass thanks on to Karen and Nikki. Karen's actually at a joint session around mental health at the moment, because we are very keen that we join the two services up more. So thanks to them.
Thank you very much. And actually, an emerging issue in Tayside that came up, I've been able to escalate to a national level because it was such an anomaly. So watch this space. So I'm asking you to endorse the annual and accept a level of reasonable assurance around the activity therein. Is everyone happy with that? Great. I'm going to ask you not to pack everything away. Sorry? The lights have just gone on. Oh, crikey, Christmas lights have gone on. Right, I'm going to ask you to hang on, and I would like the recording to continue after we finish with the final item on the agenda, which is the date of the next meeting. So please don't go away. So the date of the next meeting is the 13th of December at 2 o'clock. And the reason I'm asking you to hold on is that this is the last IGB meeting of this woman. I have known Gail for about a quarter of a century, but I knew of her long before I met her. Wow. Her reputation went before her, and she was nursing in Stracathro at that time, and I have been able to watch from the sidelines the way Gail's career has progressed until where she is today. She has been an amazing leader as a nurse and as a manager. She has been completely committed and dedicated to quality improvement in everything that she does. She is passionate about continuous professional development and has walked the walk on that, and has actively encouraged so many of our peers and colleagues to do the same. But at the total heart of everything Gail does is the people who need the care. if I was needing care and Gail was looking after me, I would trust her with my whole being. She is a passionate advocate for excellent services. She's wonderful to work with. I'm going to miss her, and I know everybody else is. And I'm hanging together by a thread here. But I'm really hoping that any of our staff, our colleagues across national and local networks get the chance to see this and to take part in any of our leaving dues. Like me, she's got more than one on the go. Please do join in. I know it's going to be a big wrench for us. I know she has left the team in a fantastic position, so I have no anxieties about the next step. But I would just like to take this opportunity to thank Gail for her public service over 40 years. It's like 42 years. Yeah. Yeah. No, it's not 2001 anymore. And I know you'll all agree with me that she has been fantastic to work with and so passionate about keeping good services at the centre of everything that we do, and gentle and kind and actually robust as well when she needs to be, which is fantastic to see. She will take things on that are difficult, and she will work her way through the resolution. So please, can we just send Gail all our love for a very happy next phase of her life? Because it's not retirement, she's not going to stop, she's going to be all over the place. We all know what Gail's like, and she won't be reading emails that I send out at stupid o'clock either, just because it's convenient for me. So I'm getting signalled, so, it's behind you, it's Panther season. So I didn't know that. I didn't even notice anyone. So Gail, please, this is an interim gift from the IGB in advance of your proper leaving due.
Oh dear. Well, in fact, I'm going to take them back. July 1981. Gosh, when was that, Andrew? I can't even remember back then. Well, that's not strictly true, actually. I can remember my first day very clearly. I've been one of these lucky people that chose the right career for myself, and I've had a fantastic 42 and a half years working in health and social care. It's been an absolute privilege. And I say that to people every day. I've been paid for my hobby. I've just absolutely loved my career, and I've been so fortunate, and opportunities have arisen all over the place. And as Julie said, it's not always been easy, but I always try and keep people at the heart of that, no matter who people are. What I would like to do, though, is bring you back to the IGB. And a wee bit of history here. I've had a knot in my stomach this afternoon, so apologies for that, but I've managed to avoid getting up and going out because I was frightened I wouldn't have come back. So reflecting on that, I don't know if Julie remembers, but our first inaugural meeting of the Angus Interim Shadow Board was actually chaired by the late Glynis Middleton on the 29th of April 2015. And I have great memories of that day because we actually didn't know what we were doing. And the preparatory work going on behind the scene was immense, because this was a new direction from the Scottish Government and we didn't know what it entailed. But I'm delighted to say we actually had a special meeting in October, on the 6th of October, where we were far more organised, and we then decided we would go public on the 18th of May 2016, and that was far more organised. We'd had all the briefings, but I don't think in that 6 months I really did much more than prepare for this IGB when it was starting. At that point I was the head of service up until the 1st of April 2016, where George Bowie and I were appointed to our new roles for the IJB, where I was responsible for the north and George was responsible for the south, where we had significant portfolios alongside that. As you know, I took up the interim chief officer post way back in February 2020, which was 3 weeks before COVID commenced. So the post I thought I was taking up was a very different post to that I needed to do. So again, I had to dig deep and look at different leadership skills and different requirements over that few years. And when I reflect back, I keep thinking, was that the hardest bit? Was that the hardest bit? You know, which bit was the most challenging? But actually, when I look back, I just look at all of you and think how proud I am, because I'm supported by the most fabulous, fantastic team. And I have no qualms whatsoever about all of the team. I'm not going to cry, I'm trying hard not to cry, about leaving everybody that are there. And Julie, yourself, Lois, Sandy, Catherine, Lindsay, a number of you have been there from that word go, from when we started. And I honestly can't believe how far we come. In fact, Councillor Speed, I'm reflecting back on your first few meetings where Lois actually didn't speak. She didn't speak at all. And she was very quiet, Lois. I don't know if you can remember back in these days as well, but there's a lot of changes. No comment, Councillor. Yeah. But I must say, this weekend in particular, with the storm and everything else, I've never been more proud of my team and what they've done. And I've tried really hard to stand back from the Gold Commander, as Eunice calls me, stand back and let the team step up. It's not easy. It's not easy being me, and it's not easy standing back. And I'm really struggling with it all, but I will learn without needing support from GPs and mental health, I hope, for how I withdraw from all of this, but it's not easy. But again, I want to wish all of you the very, very best of everything. You've got challenges ahead, particularly with whatever's been introduced through the National Care Service and others, but I'm leaving you all in very capable hands. I think I've made it look easy, so good luck to everybody. Thank you.
So I'm hoping all of you can make it along to Gail's leaving dues. You're all invited. And on that note, with again deep gratitude to all our staff and to Gail. Safe journey home, watch the weather, and we'll see you in December. Take care.